Hey guys, welcome back to the part 2 of the revision sessions that we are conducting. Hi Dr. Vinod. Hi Dr. Satyam. Hi Dr. Rachna. Hi Dr. Guera. Hi everyone. Are you able to see and hear me? If you are able to see and hear me, you can give a quick thumbs up. Hi Dr. Soumya, good evening. Hi Dr. Asim, good evening. Hi Dr. Roshan. Hi Dr. Krunal. Good evening everyone. I'm good. I hope you're all doing good as well. Yeah. So if you're able to see and hear me, we are good to go. So this is the part 2 and it is going to be the continuation of the previous session. So we're going to continue from where we left in the previous session. So I think we have discussed on rheumatoid arthritis and its treatment. So I think this is the one that we have discussed in the last session. Now we'll be moving on to the next slide, that is on seronegative spondyloarthropathies. So we have plenty to discuss. I have to discuss around like 25-30 more topics. So let us start the discussion straight away. So first, number 1. So what are the SSAs? So what do you mean by the term SSAs and what are SSAs? These are nothing but seronegative spondyloarthropathy. So what do you mean by the term seronegative? Seronegative means the patients should be RF negative, rheumatoid factor negative, ACPA negative. You know what is ACPA? These are anti-citrullinated peptide antibodies. The best example for an ACPA antibody is going to be anti-CCP. And more importantly, many people don't understand this fact that the patient should be ANA negative as well. So this is very, very important. So many times you do only RF and anti-CCP, but you don't do ANA. So you have to know that ANA is also important. ANA should also be negative. So if all these three are negative, and if the patient is having arthritis, then you can probably call it as a seronegative arthritis. What do you mean by seronegative spondyloarthropathies? Spondyloarthropathies means they can cause spine involvement, which means they will commonly cause spine involvement. Along with that, they can also cause peripheral arthritis as well. Peripheral arthritis. So they can cause peripheral arthritis also. So this is what you mean by spondyloarthropathies. Okay, so now you know what is the definition of seronegative spondyloarthropathies, and majority of the seronegative spondyloarthropathies tend to be HLA-B27 positive. I'll repeat, majority of the SSAs will be HLA-B27 positive. And honestly speaking, the SSA are all about the spine involvement, the axial involvement. Whenever the patient is HLA-B27 positive, they correlate with the axial involvement. So some patients may be HLA-B27 negative, but in case if they are HLA-B27 negative, they don't usually have axial involvement. So whenever patient is HLA-B27 positive, those patients are the ones who tend to have axial involvement. So what do you mean by axial involvement? The spinal involvement, the lumbar or probably thoracic spine, very commonly lumbar spine. And they might have sacroiliitis also. So this is what we typically refer to as something called as axial involvement or axial skeletal involvement. So this is the definition of SSAs. And we have 4 important SSAs, as we all know. One is ankylosing spondylitis. Second one is going to be the psoriatic arthritis. Simply I can write as PSA. Third one, we have something called as reactive arthritis. The old name for reactive arthritis is something called as Reiter's syndrome. And finally, last but not the least, we have something called enteropathic arthritis, which are associated with IBD, associated with inflammatory bowel disease. Okay, IBD. So we have 4 different types of SSAs. Among the 4 SSAs, what are the things that are going to see in common? So let me write certain things that you're going to see in common. So what are the common features? Common features means this can be seen in all the patients with SSAs. And I'm not telling that this will be seen in all the patients. This may be seen in all the patients. Okay, and these are common features. Number 1. So what are the number 1 feature? So that is the inflammatory back pain, otherwise called as IBP. So what do you mean by inflammatory back pain? It's a typical inflammatory kind of an arthritis where the patient will have early morning stiffness that is going to be prolonged for more than 1 hour generally, and the patient's pain and stiffness will resolve as they start doing some physical activity. As the day progresses, the pain and stiffness will come down. That is typical of an inflammatory arthritis. And if they take rest, the pain will increase. The pain and stiffness will increase. And typically the IBP, the inflammatory back pain, will respond excellently to NSAIDs. And sometimes with hot water fermentation also, it tends to respond excellently. Okay, so that is all about the inflammatory back pain that you need to know. They tend to respond very nicely to NSAIDs, and they tend to respond very nicely to your hot water fermentation, application of hot bath as well. Second, point number 2. Patients tend to have something called as enthesitis. So what do you mean by enthesitis? Inflammation of the areas of insertion of tendons and ligaments. These are called as enthesitis. These sites are basically called as entheses, and if those sites are inflamed, we're going to call it as enthesitis. And enthesitis is very, very common in patients with ankylosing spondylitis. It's common in patients with psoriatic arthritis and reactive arthritis also, but it's quite uncommon in patients with enteropathic arthritis, that is IBD-associated arthritis. What are the examples of enthesitis? The most common site for enthesitis is going to be the Achilles tendon, the Achilles tendinitis, which can cause heel pain, or patients may have associated plantar fasciitis also, which can cause heel pain. So this is an example of enthesitis. Number 3, patients can have anterior uveitis. So remember, if at all in exam, if they ask you one thing that does not occur in rheumatoid arthritis or any other seropositive arthritis, including Sjogren's syndrome, including SLE, answer will be anterior uveitis, because this is a feature of seronegative spondyloarthropathy. In fact, this is the most common extra-articular manifestation of seronegative spondyloarthropathy. If somebody asks you what is the most common extra-articular manifestation of SSAs, answer is anterior uveitis. If there is one thing that's not going to occur in any other seropositive arthritis like rheumatoid arthritis, answer also will be anterior uveitis, because that is not a feature. I'm repeating again, that's not a feature of seropositive arthritis like RA. It doesn't occur. And point number 4, patients can have dactylitis. So what do you mean by dactylitis? Dactylitis. So here there will be inflammation of the entire digit, okay, resulting in something called a sausage-shaped digit. So this is what we call it as dactylitis. And dactylitis is common in patients with psoriatic arthritis and Ritter syndrome, reactive arthritis. It is uncommon in ankylosing spondylitis. I'll repeat, dactylitis is uncommon in ankylosing spondylitis. It's going to be common in psoriatic arthritis and reactive arthritis only. So these are the most important features that are going to be common in any case of seronegative spondyloarthropathies. Okay. So coming to each and every single seronegative spondyloarthropathy, ankylosing spondylitis. The most important thing is the age, epidemiological features. So age will be less than 40. Younger population will be affected because of ankylosing spondylitis. And mostly it will be males. Okay. And they're going to present with typical inflammatory back pain. So this will be the presentation. Or examiners may also use the term alternating buttock pain. And more importantly, these patients also tend to have extra-articular features. What are the most important extra-articular features? Patients can have aortic regurgitation. If at all they ask you what is the most common valvular heart disease in patients with ankylosing spondylitis, answer is AR. Most common valvular heart disease in patients with ankylosing spondylitis, aortic regurgitation. And these patients also tend to have associated upper lobe fibrosis. I'll repeat, it's a very important cause of secondary interstitial lung disease, and they can cause upper lobe fibrosis as well. Upper lobe fibrosis. That is the reason why in exam, if they give you a young male presenting with reduced chest expansion and back pain, it is a stereotypical question. Answer is ankylosing spondylitis. Reduced chest expansion, back pain. Close your eyes. Click on ankylosing spondylitis, because this is a stereotypical question. Very important. And what is the first line investigation? First investigation that you're going to do? X-rays. I think orthopedician or radiologist used to say that there is a view called as Ferguson's view that we specifically use to image the sacroiliac joint. Okay, because sacroiliitis is one of the early features of ankylosing spondylitis. So look at the sacroiliac joint for ankylosis of the SI joint. That indicates sacroiliitis, which is a very important feature of ankylosing spondylitis. If X-ray is normal, okay, in X-ray, if you don't see any change and if you have a high level of suspicion of ankylosing spondylitis, do an MRI of the sacroiliac joint. What are you going to do? MRI of the sacroiliac joint, where you're going to see bone marrow edema. I'll repeat, you're going to see bone marrow edema, which is also suggestive of the inflammation of the sacroiliac joint. That is otherwise called as sacroiliitis. If MRI is also normal, ankylosing spondylitis is unlikely. Okay, ankylosing spondylitis is also unlikely. If MRI is also normal, ankylosing spondylitis is unlikely. It's very, very unlikely. It's not possible. Okay. What is the role of HLA-B27 testing? HLA-B27 has a very high negative predictive value in patients with ankylosing spondylitis. More than 90 to 95% cases of ankylosing spondylitis will be HLA-B27 positive. So which means you can test HLA-B27, but the problem is if HLA-B27 is positive, it doesn't have any value, because according to Harrison, 30 to 35% of the American population tend to have HLA-B27 positivity. That doesn't mean everyone is going to develop ankylosing spondylitis. So positive HLA-B27 doesn't have any much impact. But if the HLA-B27 is negative, okay, then it almost rules out ankylosing spondylitis. So it's a kind of investigation. It's like a D-dimer where you have a high negative predictive value, so you can rule out in case the investigation is negative, but apart from that, you cannot confirm because of the positivity of HLA-B27. So it's like kind of a controversial investigation. If you want, you can do, but generally we don't prefer. So what about the treatment? Treatment is going to be NSAIDs. The first line treatment is NSAIDs because most of the patients will suffer from severe IBP, inflammatory back pain, that responds excellently to NSAIDs. So first line will be NSAIDs, but unfortunately NSAIDs are not going to be disease modifying. It's not a disease modifying drug. So DMD stands for disease modifying drug. It's not a disease modifying drug. If at all they ask you in ankylosing spondylitis, what is the disease modifying drug? It is anti-TNF. Anti-TNF are going to be one of the best group of drugs as far as a ankylosing spondylitis is concerned. Few anti-TNF drugs are approved for use in ankylosing spondylitis. That much level of data are not required. Steroids we don't use in generally in ankylosing spondylitis. We don't prefer using steroids unless until if there is a severe acute flare. Steroids will work for peripheral arthritis, but again for the spinal arthritis and sacroiliitis, axial joint involvement, steroids are not going to be that effective. And all the traditional DMARDs, the traditional disease modifying drugs like methotrexate and whatever sulfasalazine HCQ that you use are also not going to be very effective for the axial arthritis. It's only for peripheral arthritis. So anti-TNF is very, very important. And apart from that, there are some new drugs that are approved for ankylosing spondylitis. One is anti-IL-12, IL-23 combined inhibitor. This is called as ustekinumab. I'll repeat, that's called as ustekinumab. This could be a potential MCQ in your exams. In fact, this is asked in 2018 PGI exam. So ustekinumab, it is a combined anti-IL-12 and IL-23 inhibitor because IL-12 is very, very important for the T helper 1 pathway and IL-23 is very, very important for the T helper 17 pathway. These are extremely pro-inflammatory pathway, so you can block both with the help of ustekinumab. Okay, so that's a drug that is approved. Secukinumab is more for psoriatic arthritis. You can use for ankylosing spondylitis. Secukinumab is an anti-IL-17 inhibitor. Secukinumab, it's available in India, to be honest. Ustekinumab is not available in India, but secukinumab is available in India right now. In fact, I started using quite long ago, and it's more for psoriatic arthritis and psoriasis. But you can use in some selected patients with ankylosing spondylitis also. So secukinumab, anti-IL-17 inhibitor, that is secukinumab. So this is ankylosing spondylitis. So what are the X-ray changes? Ankylosing spondylitis is quite a common disease. It's not very uncommon. You can see if you are in a good tertiary care center, probably you might be able to see at least 1 or 2 cases in a month. So it's quite common depending on the load of the patients that you have. In my practice, I see at least like 1 case a month minimum. So what about X-rays? So X-ray changes or radiological changes, I think everyone will know. So shiny corner sign is a very, very important sign. They would have taught you in orthopedics. And then we have the classic bamboo spine appearance. You have the dagger sign. So these are all like advanced signs. Dagger sign, bamboo sign. So you have plenty of signs that you can see, like a shiny corner sign, bamboo sign, dagger sign. So many signs are there. Okay. But in exam, this is the single most important picture that you need to know. So we are going to have ankylosis of the sacroiliac joints. I think you can see that properly here. You can see ankylosis of the sacroiliac joints, right? So you can see ankylosis of the sacroiliac joint. Sacroiliac joint fusion. You're not able to see the joint line at all. So whenever in exam they use the term bilateral symmetric sacroiliitis, bilateral symmetric sacroiliitis, or they use the term bilateral symmetric syndesmophytes, bilateral symmetric syndesmophytes. Answer is ankylosing spondylitis. Bilateral symmetric sacroiliitis. Just like keep it in your mind. Bilateral symmetric sacroiliitis means ankylosing spondylitis. Bilateral symmetric syndesmophytes, it's equal to ankylosing spondylitis. Somebody is commenting about the Schober test. Yes, Schober test is a good test to find out the spinal motion. Okay, but it's not a good test to confirm ankylosing spondylitis. Because anything that affects the spinal movement, the lumbar spine movement, is going to cause a positive Schober's test. What is Schober's test? You ask the patient to stand erect and mark a 10 centimeter line in the lumbar spine. Ask the patient to bend down and as much as possible, and now recheck the 2 points. It should be increased by at least 5 centimeter or more from the baseline value. If it's not increased by more than 5 centimeter, we can call it as limited lumbar spine motion. So limited lumbar spine motion can be seen in anyone with a problem that affects the lumbar spine. So it's not a specific test for ankylosing spondylitis, but yes, there are plenty of other tests. Okay, so that you can do for sacroiliitis and all, but that's not a very high yielding information, by the way. Okay, so now what about psoriatic arthritis? Psoriatic arthritis is quite simple. So it's an RA mimic. The most important thing that you need to know is it's an RA mimic. So point number 1. So many times it can mimic RA. In fact, the age group that is affected by psoriatic arthritis also can be more than 40. So like rheumatoid arthritis. And patients can present with typical peripheral arthritis. Spondylitis due to psoriatic arthritis may not be common. Okay, and patients predominantly present with peripheral arthritis like rheumatoid arthritis, and they can have a characteristic rheumatoid distribution of arthritis also, and they can present with a bilateral symmetric polyarthritis like rheumatoid arthritis. So it's a very important point. It can present like a rheumatoid arthritis, an RA mimic. And added on to the confusion, 20% of psoriatic arthritis patients may not have skin lesions. 20% may not have skin lesions. This is another high yielding point for exams. Okay, 80% of patients will have some skin lesions, but 20% may not have skin lesions, which means psoriatic arthritis can present by itself without any skin lesions or nail lesions. Okay, so third clue in exam will be the DIP involvement. Okay, so DIP involvement is very classic of psoriatic arthritis. And the fourth point that you need to know is in X-ray, you're going to see the classic penicillin cup DIP deformity. So penicillin cup DIP deformity, this is the fourth thing that they will ask. And other things you would have studied in dermatology. What are the psoriatic nail changes? What are the different types of psoriasis and all those things? Which are the areas that you have to specifically look for psoriasis, like behind the ears, scalp, around the umbilicus. So these are very important areas that you have to look, because those areas psoriasis may be hidden, which may not be obvious. Yes, we have something called Casper criteria for diagnosing psoriatic arthritis. So plenty of things are there, but I'm telling only the important points because this is a revision session. And what about the treatment? So treatment of psoriatic arthritis is pretty simple. You can use methotrexate, which works for both psoriatic arthritis as well as your psoriatic skin lesions, and you can use anti-TNF alpha drugs. Okay, and you can use anti-IL-17. Okay, IL-17 drugs like secukinumab, which are basically more for psoriatic arthritis and psoriasis compared to that of your ankylosing spondylitis. And there is a new drug called as apremilast. I don't know how many of you know that. There's something called as apremilast. Apremilast is a drug that is a phosphodiesterase 4 inhibitor that is approved for use in psoriatic arthritis. That's called apremilast. It's a phosphodiesterase 4 inhibitor. So what about reactive arthritis? Reactive arthritis means it's a reaction to infection. So before that, let me show you the changes in psoriatic arthritis. So you can see this is a classic and typical penicillin cup DIP deformity. You can see over here, you can see over here. So DIP involvement is very classic, and it's a classic penicillin cup DIP deformity. Okay, so what about reactive arthritis? So reactive arthritis is an arthritis that occurs due to reaction to some underlying infection. For example, patients can have a GI infection, gastrointestinal infection, or a genitourinary infection. And after this gastrointestinal genitourinary infection, patients can develop arthritis plus or minus spondylitis. So this is what we call as reactive arthritis. And they don't just present with arthritis, they tend to present with a characteristic triad. So that is arthritis conjunctivitis, okay, arthritis conjunctivitis and urethritis. I'll repeat, arthritis conjunctivitis and urethritis. This is the characteristic triad that the patient is going to present with. Arthritis, conjunctivitis, urethritis. This is a triad of Reiter's syndrome. And they can have some classic skin lesions as well, which are very typical of reactive arthritis. What are the two important skin lesions? One is the keratoderma blenneragicum, which is called as keratoderma blenneragicum, or simply we can write as KB lesions, keratoderma blenneragicum. And second lesion is going to be the succinate balanitis. You can see these are inflammation of the gland spinis, or is called as succinate balanitis, two skin lesions. So a gastrointestinal or a genitourinary infection, for example, it could be a diarrhea or it could be STD. The most important STD is chlamydia. The most important STD is chlamydia. So after a diarrhea or after a STD, if you develop the classic triad of arthritis, conjunctivitis and urethritis along with the typical skin lesions, you can make a diagnosis of reactive arthritis or Reiter's syndrome. And remember, it is a self-limiting disease. Treatment is just like for short-lived. So most of the patients will have a good resolution within 1 year. It's a self-limited disease. Now coming to enteropathic arthritis. You know, enteropathic arthritis will have typical association with inflammatory bowel disease. There are two types of enteropathic arthritis, type 1 and type 2, which is not a very high yielding point for exam. Type 1 typically presents with asymmetric oligoarticular pattern, and type 2 will present with a symmetric polyarticular pattern, sometimes can mimic a rheumatoid arthritis. But whenever in exam you have a patient with IBD, like Crohn's disease or ulcerative colitis, plus having a peripheral arthritis predominantly, think about enteropathic arthritis. Remember, all are examples of peripheral arthritis. Enteropathic arthritis, reactive arthritis, as well as psoriatic arthritis are all examples of peripheral arthritis, except ankylosing spondylitis, which is most importantly a axial arthritis. Ankylosing spondylitis is typically axial predominant, but all other three arthritis are basically peripheral predominant arthritis. Now let us move on to the next slide. So next slide, which is a high yielding slide. This is a slide on SLE antibodies. So this is one of our patients who presenting with malar rash. Okay, so this is a very common picture in your exams. So you know, like importance of the malar rash. The rash will spare the nasolabial folds, and the rash is going to be butterfly shaped, and it can cross the nasal bridge. And one of the important differential diagnoses for that is acne rosacea, which will involve the nasolabial fold. So that is the reason why we need to know this point, that malar rash is going to spare the nasolabial folds. And here is an example of neonatal lupus. They will commonly ask in exams neonatal lupus, which is commonly associated with an antibody called as anti-Rho antibody. So there are two types of anti-Rho antibodies. One is 52 kilodalton type and 60 kilodalton type. If they specifically ask you what is the type that is associated with neonatal lupus, it is the 52 kilodalton low molecular weight type. So the 60 kilodalton type is not related to neonatal lupus, but related to many other manifestations of anti-Rho antibodies. So remember, whenever the child is having neonatal lupus, or if the child is having anti-Rho antibodies in their system because the mother would have transmitted those anti-Rho antibodies, this child is at high risk of developing complete heart block as well. Complete heart block. Even this is an important point. The child is at high risk of complete heart block, and this is a irreversible complete heart block. If it occurs, it's irreversible and it will require a permanent pacemaker. So what are the important SLE related antibodies? Number one, you need to know about the ANA. So that is anti-nuclear antibody. Anti-nuclear antibody is having high sensitivity, which means a negative ANA essentially rules out SLE. So high sensitivity in the sense, the sensitivity is more than 98 to 99%, which means a single ANA, or if you are having a doubt, you do 2 times ANA, and if it's negative, 100% it rules out SLE. It's not SLE. But the problem is it has very, very poor specificity. It has an extremely poor specificity. Very poor specificity, in fact. So how can I say it can be present in multiple other conditions? Even like 2 to 3% of the general population itself can have ANA in very low titers. So it's a antibody that's going to have very poor specificity. So you need to work up further. What are the other antibodies that come under the umbrella of ANA? So next is anti-dsDNA antibodies. So what about anti-dsDNA antibody? Anti-dsDNA antibody is specific. Okay, only 2 points are important. It's a specific, but even though it's not the most specific, and it has a good association with something called as lupus nephritis. I'll repeat, it has an excellent association with something called as lupus nephritis. That's a very important point. And it's not a sensitive antibody. It is present only in 30 to 50% cases. In 50 to 70% cases, it can be negative. Okay, but it's very specific. It's quite specific, and it's going to correlate with something called as lupus nephritis. And we have another antibody called as anti-Smith antibody. So anti-Smith antibody is going to be the most specific on paper. So in case if somebody asks you what is the most specific antibody, that is anti-Smith antibody. But it doesn't correlate with any particular manifestation in SLE, but it is the most specific, but present only in 10 to 20% cases. So 80 to 90% cases may test for anti-Smith negative, but it is the most specific, almost 100% specificity. And you have another antibody called as anti-Rho antibody and anti-La antibody. Anti-Rho and La antibodies are also called as anti-SSA and SSB antibodies. Why it is called as anti-SSA and SSB antibodies? Because it is originally known to be associated with Sjogren syndrome. It is originally known to be associated with Sjogren syndrome. That's why it is called as SSA and SSB, Sjogren syndrome associated antibodies, SSA and SSB. But anti-Rho and La can be present in any patient, especially in patients with SLE, where it's going to correlate with plenty of manifestations like SCLE, that's called subacute cutaneous lupus erythematosus, then photosensitivity in lupus, then lupus-related myositis, then lupus-related myocarditis, okay, then lupus-related shrinking lung syndrome, that's called SLS, where the lung appears to shrink. That is because of diaphragmatic and intercostal myositis, which when gets weakened, the lung becomes small because of the elastic recoil. So it looks as if the lung is shrinking in this patient. So that's called as shrinking lung syndrome. And apart from this, patients can have associated neonatal lupus, which is something I told you already, neonatal lupus. And patients can have NMO spectrum disorder, NMOSD. Even this is associated with anti-Ro antibodies. I'll repeat, NMO spectrum disorder, NMO spectrum disorder, NMOSD. And only good thing that these antibodies are going to do is that is reduce risk of lupus nephritis. Only good thing that these antibodies do is reduce risk of lupus nephritis. That's all. Apart from that, nothing else with anti-Ro and anti-La. And then we have another antibody, okay, that is going to come under the ANA spectrum. These are called as anti-histone antibodies. Remember, it can be seen in SLE. In fact, around 70 to 90% case of SLE will have anti-histone antibodies, which means it's not quite specific for SLE, but it's relatively specific for another disease called as drug-induced lupus erythematosus. Drug-induced lupus erythematosus. Even though it's not specific for SLE as such, but can be seen in SLE, it's quite specific for another disorder called as DILE, that is drug-induced lupus erythematosus. Dr. Medici is asking this also for NEET. Yes, I told you so many times in the previous session itself that NEET and FMG are not very different exams. The difficulty level is almost going to be on par with each other, and the only difference being that FMG exam is a kind of qualifying exam, and NEET exam is a competitive exam. That's the only difference. Apart from that, there's no much difference. And everyone, I think you would have studied in pharmacology, there are some drugs that induce drug-induced lupus. So the most important are the class 1A antiarrhythmics. This is regularly asked in exam. Class 1A antiarrhythmic drugs, disopyramide, procainamide and quinidine. And next is your infliximab, and sometimes interferons also. Infliximab means anti-TNF drugs. This is also very commonly asked in exam, anti-TNF alpha drugs. And some other drugs like minocycline. Minocycline is important for USMLE exams. In India, I don't think how much minocycline-induced DILE cases you see, but in USMLE, this is a very important question. Minocycline-induced, drug-induced lupus erythematosus. And to be honest, minocycline-related lupus may have a negative antihistone. I'll repeat, minocycline and infliximab-induced lupus can have a negative antihistone. Again, I'll repeat, minocycline and infliximab-related drug-induced lupus can have a negative antihistone antibodies. In exam, usually they will target the minocycline only, because only 12 to 15% of minocycline-induced drug-induced lupus will have a positive antihistone antibodies, which means most of the times it will be negative. That's the importance of minocycline and infliximab. And many of you have commented, yes, hydralazine is a very important drug, and even isoniazid, INH, is a very important drug. So there are plenty of drugs. Okay, sulfur drugs are important. So many of you can remember with the mnemonic SHIP. So whatever it is. But for me, the 1A antiarrhythmics, infliximab, is the most important, because an anti-TNF drugs, because these are the drugs that we are commonly using in practice. Minocycline not so commonly used, hydralazine not so commonly used, INH very rarely it causes drug-induced lupus. In Indians, it's unlikely. Okay, so antihistone done. Okay, then what about other antibodies? We have something called anti-U1 RNP antibodies, which is more commonly associated with a disease called as MCTD, otherwise called as mixed CTD or mixed connective tissue disorder, mixed connective tissue disorder. And then we have another antibody called as anti-ribosomal protein antibody. So anti-ribosomal protein antibody was long thought to be associated with psychiatric manifestations in lupus. So why this point became famous? Because this is given in Harrison, that's why. The problem is, in many of the rheumatology chapters in Harrison have not been updated so far. Trust me, I'm not telling that Harrison is wrong, or I'm not telling that Harrison is not a good book. I'm not qualified enough to comment that something is wrong in Harrison or something is not updated in Harrison. But trust me, the true thing is, many things have not been updated in Harrison as well as the rheumatology section is concerned. So they are still giving that anti-ribosomal protein antibodies are associated with psychiatric manifestations in lupus. Actually, right now, there is no evidence to say that anti-ribosomal protein antibodies are associated with psychiatric manifestations in lupus. Okay, actually, it's the APLA antibodies, the antiphospholipid antibodies, that are associated with psychiatric manifestations in lupus. So you don't usually currently use the term APLA, because that's the traditional term that we use, but currently we should use the term APL, antiphospholipid antibodies, or simply APL. So these antibodies are the ones that are associated with psychiatric manifestation lupus like psychosis, depression. And apart from that, they are also associated with thrombosis, thrombocytopenia, and obstetric complications like recurrent pregnancy loss. So what is the final take-home point? Don't create any sort of controversy here because it's mentioned in Harrison. Whenever you appear for NEET exam or FMGE exams, just go for anti-ribosomal protein antibodies that are associated with psychiatric manifestation, because most of the times your NEET PG FMGE questions will be straight from Harrison or CMDT. That's it. But if they ask in INI-CET exam specifically, which is associated with psychiatric manifestations, there probably you might answer antiphospholipid antibodies. Otherwise, don't create any controversies. NEET FMG, answer anti-ribosomal protein antibody. That's it. But what are the important things that are associated with antiphospholipid antibodies? Thrombosis, thrombocytopenia, and recurrent pregnancy loss. And everyone knows that there are 3 antiphospholipid antibodies which are more important for exam. One is the anti-cardiolipin IgM and IgG fraction, or simply anti-cardiolipin antibodies. We can write as ACL antibodies. Second one will be the anti-beta-2 glycoprotein 1 antibody, or simply I can write anti-beta-2 GP1. And third is the lupus anticoagulant, LA. So lupus anticoagulant. Recurrent pregnancy loss specific to first trimester? Actually no. According to textbooks, most of the recurrent pregnancy loss due to antiphospholipid antibodies occurs in the second trimester because they cause thrombosis of the placental vessels. You know, placenta tends to form during the early part of the second trimester only, by around 10 to 12 weeks only. So that time there will be thrombosis of the placental arteries and veins. So that is the reason why you tend to develop pregnancy loss. So second trimester loss is more common than the first trimester loss, technically speaking. But it's not like first trimester you won't see pregnancy loss. First trimester also you will be able to see pregnancy loss. Okay, so both it can occur in first or second trimester, but second is relatively more important. But you can see in first also. So anyways, so these are 3 important antibodies that are supposed to be asked in exams: anti-cardiolipin antibody, anti-beta-2 glycoprotein 1 antibody, and third is lupus anticoagulant. In that, if they ask you the core molecule in antiphospholipid syndrome, it is glycoprotein 1, beta-2 glycoprotein 1 fraction. That beta-2 glycoprotein 1 is the central substance, the core molecule in patients with antiphospholipid antibody syndrome, or probably APS. Okay, fine. This is done. So we have discussed about the important antibodies in SLE, and there are some other antibodies that you may need to consider. Okay, for exams, what are the other antibodies that may be asked in exam? Number 1 is the anti-centromeric antibodies, that is ACA, which is associated with something called as limited scleroderma or limited SSC, limited systemic sclerosis or limited scleroderma. Remember, this is also called as CREST syndrome. The old name for limited scleroderma is CREST syndrome. C stands for calcinosis cutis, R stands for Raynaud's, E stands for esophageal dysmotility, S stands for sclerodactyly, and T stands for telangiectasias. And there is a high risk of pulmonary artery hypertension. Whenever ACA is positive, pulmonary artery hypertension risk is very high, which is one of the important reasons for death in patients with CREST syndrome. And second, we have something called as anti-SEL70 antibodies, or otherwise called as anti-topoisomerase 1 antibody. Anti-SEL70 or anti-topoisomerase 1 antibody, which is associated with something called as diffuse scleroderma, and this is associated with something called as ILD, interstitial lung disease, and to some extent is also associated with scleroderma renal crisis, but the most important association is going to be ILD, interstitial lung disease. And whenever ILD occurs in a connective tissue disorder, apart from rheumatoid arthritis, in exam answer NSIP pattern. So whenever you have a patient with ILD due to a connective tissue disorder, and if it is not rheumatoid arthritis, answer will be NSIP. If it's rheumatoid arthritis, the answer will be UIP, usual interstitial pneumonia. Number 3, we have another antibody called as anti-RNA polymerase 3 antibody. Anti-RNA polymerase 3 antibody that is commonly associated with scleroderma renal crisis, SRC. And if they ask you treatment of choice for SRC, ACE inhibitors. So if they mention the word SRC, ACE inhibitor. SRC, ACE inhibitor. That's all. That's the treatment of choice. Okay, there are some other antibodies as well. Like for example, we have anti-Jo1 antibody, which is an example of synthetase antibody. There are plenty of synthetase antibodies, but the most common synthetase antibody is anti-Joan antibody, which is associated with the syndrome called as synthetase syndrome, which is associated with something called as synthetase syndrome. So what are the features of synthetase syndrome? Common question in exam. The patients can have fever, patients can have arthritis, and more importantly, patients can have something called as the Raynaud's phenomenon, and patients are going to have something called as mechanics hands. Okay, mechanics hands, and patients also tend to have ILD, interstitial lung disease. Okay, so these are the 5 important features of synthetase syndrome: fever, arthritis, Raynaud's, mechanics hands, and ILD. So in exam, the usual point that they're going to target is the mechanics hands. Apart from that, one more association is polymyositis that we forgot, isn't it? Because it's a kind of a myositis associated antibody. So polymyositis is also very important. So 5 important features along with polymyositis. And that mechanics hands is the one that they will target. That's associated with synthetase syndrome and anti-Joan antibodies. So now I think the most important antibodies in SLE and in rheumatology are over. Next, we'll move on to important vasculitis. So what are the important vasculitis that you need to know? So first, we have large vessel vasculitis, right? Among the large vessel vasculitis, you have giant cell arteritis and Takay's arteritis. Okay, I'm writing just GC and Takay's arteritis. And we have medium vessel vasculitis. Among the medium vessel vasculitis, the most important vasculitis is PAN. And then we have the small vessel vasculitis. In the small vessel vasculitis, we have 2 types. One is ANCA-associated vasculitis and second is immune complex related vasculitis. So I'll come back to that, what are the different types in a while. But when you talk about ANCA-associated vasculitis, 3 things are there: vaginous, Chooks-Strauss, and microscopic polyangiopathy. If it's an immune complex vasculitis, you have henoch-Schönlein purpura and you're going to have probably cryoglobulinemia. These 2 are more important. And we have multivessel vasculitis like Behçet syndrome. And Kawasaki, I'm not going to talk here because it's a pediatric disease. Maybe if I want, I'll tell you some interesting points about Kawasaki as well. So first, you have to consider epidemiology. So who are going to be affected with giant cell arteritis predominantly? So giant cell arteritis predominantly is going to affect females over 50 years. It's a disease of elderly. Many times, okay, the patients will be very old, like 70, 80, in giant cell arteritis. Takay's arteritis is going to affect females who are younger, less than 40 years. Okay, females less than 40 years. That's the epidemiological distribution of Takay's arteritis. And remember, giant cell arteritis is going to affect Caucasians predominantly. It's a disease of white race. In India, it's very difficult to diagnose a giant cell arteritis, even though some people do that. But you have to be very suspicious. Unless until the biopsy is very typical of giant cell arteritis, we don't make a diagnosis of giant cell arteritis because it's very rare in Indian subcontinent. Takaisu, but it's very common because it's a disease of Asians. People call it rare disease, but if you are working in a good rheumatological center, probably you should be able to see at least 1 or 2 cases in a month or 2. And what about PAN? PAN typically tends to affect the middle-aged population. There is no sex distribution technically. And what about ANCA-associated vasculitis? ANCA-associated vasculitis is going to be variable. Okay, variable. It can affect any age group. Variable. So in that, the most important is the henoch-Schönlein purpura. Henoch-Schönlein purpura alone is a disease of young population. So usually it's going to affect the children and the adolescents. So you can remember, those who are aged less than 20 only is going to be affected with henoch-Schönlein purpura. So age less than 20, very important point, HSP alone. Other vasculitis, the age is variable. Then we need to know what are the different types of vascular involvement. I'll tell you the important things later on, but what are the important types of vascular involvement? So first, whether pulmonary artery will be involved or not. Lung involvement, pulmonary involvement will be there or not. When you talk about giant cell arteritis, no, there won't be pulmonary involvement. In Takay's arteritis, it's extremely rare. You don't have pulmonary artery involvement. It can be there, but it's very, very rare. In polyarteritis nodosa also, you're going to have a very rare pulmonary artery involvement or lung involvement. But in ANCA-associated vasculitis and immune complex vasculitis, it's very, very common. Okay, in ANCA-associated vasculitis and in immune complex vasculitis, pulmonary involvement is very, very common. Especially in patients with cryoglobulinemia, pulmonary involvement is more common. In HSP, pulmonary involvement is quite rare. So when you talk about pulmonary involvement, cryo more than HSP. If you talk about immune complex vasculitis. So what about GIT involvement? Gastrointestinal involvement. Gastrointestinal involvement is rare in patients with giant cell arteritis. It's very, very uncommon, but can happen, but rare in patients with Takay's arteritis. And polyarteritis nodosa, it's common, gastrointestinal involvement. In fact, these patients tend to have something called as mesenteric angiograms, mesenteric aneurysms, microaneurysms. the mesenteric artery will show aneurysms. So that point is very important. They tend to have mesenteric microaneurysms. What about oncocyte vasculitis? Oncocyte vasculitis, the GIT involvement is variable. They can have GIT involvement, but in immune complex vasculitis alone, one point is very, very important. Henoch-Schönlein purpura tend to have more GIT involvement compared to your cryoglobulinemia. So usually patients with HSP tend to present with GI involvement only. Abdominal pain, melena, intersusception are all very, very common in patients with Henoch-Schönlein purpura. So that is the reason why that point is alone very, very important. And the third important point is the renal involvement. So what about the renal involvement? Renal involvement is again uncommon in giant cell arteritis. Rarely it can occur in Takayasu arteritis. It's common in patients with polyarteritis nodosa. Common in the sense they are going to cause renal aneurysms. They are going to cause renal artery microaneurysms. They are going to cause renal artery microaneurysms. And this will result in renal infarcts. That will result in renal infarcts. These wedge-shaped renal infarcts can result in acute kidney injury. These wedge-shaped renal infarcts can also result in hematuria. But more importantly, you need to know that this hematuria is not of glomerular origin. So that is the reason why the hematuria is not going to contain RBC cause. So it's a non-glomerular hematuria, right? Or extraglomerular hematuria. That is the reason why this hematuria will not contain RBC cause. And what about your oncocyte vasculitis? Oncocyte vasculitis, your renal involvement is quite common. Okay. But here the problem is actually glomerulonephritis. I'll repeat, the problem here is glomerulonephritis, small vessel involvement, glomerular involvement. Okay. And because of the glomerular involvement, patients will have hematuria, acute kidney injury, but this hematuria will contain RBC cause. Okay, that's very important because it's a glomerular involvement. So in fact, this is a very, very important difference between PAN and oncocyte vasculitis. Usually in exam, they will ask a difference between PAN and microscopic polyangiitis. Microscopic polyangiitis is a small vessel vasculitis. PAN is a medium vessel vasculitis. And they'll ask you the difference. The one thing that separates microscopic polyangiitis and PAN in exam is the presence of RBC cause in microscopic polyangiitis, where it will be not there in the patients with PAN. So that's a very, very important difference. Please don't forget that. And same thing. Okay. So in immune complex vasculitis also, you are going to have glomerulonephritis. So patients will have same thing, hematuria and RBC cause. So same thing in immune complex vasculitis. And finally, what are the miscellaneous features that help you diagnose each and every vasculitis? So remember, headache is the most important. Headache is the most important as far as your giant cell arteritis is concerned. Headache is extremely important because the most common artery involved in patients with giant cell arteritis is superficial temporal artery, STA. So that's why headache is the most common. But if they ask you the most specific manifestation, that is jaw claudication. Jaw claudication. Jaw claudication is the most specific manifestation of giant cell arteritis, and it is due to involvement of the facial artery. It is due to involvement of the facial artery. You are going to have jaw claudication. So headache due to superficial temporal artery involvement and jaw claudication due to facial artery involvement. But the most dreaded complication of giant cell arteritis is blindness. The good news is the fact that this blindness will be preventable. It's one of the important preventable cause of blindness, but it is irreversible. And this is due to involvement of ophthalmic artery. Ophthalmic artery. So headache, jaw claudication, blindness. These are the three things that you need to know. And what about your Takayasu arteritis? Takayasu arteritis is going to involve subclavian vein, subclavian artery predominantly, because the most common artery is subclavian. They're going to present with arm claudication, arm pain and arm claudication. Giant cell arteritis, jaw claudication. Takayasu arteritis, arm claudication. Because of why arm claudication? Because the subclavian artery is the most common artery involved in Takayasu arteritis. Okay, so because of subclavian involvement, the radial artery will receive less blood. So the radial artery will become pulseless. So the pulseless radial artery is another key feature. Along with that, okay, the most important thing is these patients will have asymmetric pulse and blood pressure. Asymmetric pulse and blood pressure. Asymmetric pulse and blood pressure. So there will be differential pulse between two arms and differential BP between two arms. So that's another classic feature of Takayasu arteritis. And what about PAN? So the most important feature of PAN that may be asked in exams is many patients tend to be HbA1c positive. Not many, honestly speaking, around like approximately 5% patients can be HbA1c positive. Right now, the incidence is decreasing because of widespread hepatitis B vaccination. So right now, 5% of PAN cases are due to hepatitis B virus. So PAN is a important extrahepatic manifestation of hepatitis B virus. So HbA1c positive. Second, PAN will be having testicular involvement. So that's another key point in exam. Testicular involvement. Whenever a vasculitis involved testis, testicular pain, ovarian involvement and all, you think about polyarteritis nodosa. So HbA1c positive, testicular involvement, key features. And what about ANCA-associated vasculitis? You have three, isn't it? Vaginous granulomatous. What is vaginous granulomatous? You're going to have ENT involvement. So ENT involvement in the sense you're going to talk about the sinusitis, the the otitis media, subglottic stenosis, orbital pseudotumor. So plenty of things are there, but sinusitis is the most common. And they're going to have kidney involvement. Okay, and they tend to have kidney involvement and they tend to have lung involvement also. Lung involvement and they tend to have kidney involvement. So this is the typical feature of vaginous granulomatous, in that the ENT involvement will separate from other types of vasculitis. What about Chooks-Strauss syndrome? Chooks-Strauss syndrome patients will have bronchial asthma and eosinophilia. Chooks-Strauss syndrome patients will have bronchial asthma and eosinophilia. So what about the third disease, that is microscopic polyangiitis? Microscopic polyangiitis patients will be having kidney involvement in the form of RPGN, and they also tend to have lung involvement. So kidney and lung involvement alone. So how to differentiate microscopic polyangiitis in exam? These patients will not have ENT involvement, and microscopic polyangiitis patients will not have bronchial asthma, and microscopic polyangiitis patients will not have eosinophilia. So when you don't have eosinophilia, when you don't have bronchial asthma, when you don't have ENT involvement, only kidney lung involvement, think about the possibility of microscopic polyangiitis. And further clues will be given by the examiner in the form of ANCA. Vaginous granulomatosis will be C ANCA positive, okay, generally, whereas Chooks-Strauss and microscopic polyangiitis patients will be having P ANCA positivity. So that's the difference. So you know what is P ANCA? P ANCA is anti-myeloperoxidase antibody, whereas C ANCA is anti-proteinase 3 antibody. C ANCA is anti-proteinase 3 antibody. P ANCA is anti-myeloperoxidase antibody, whereas C ANCA is going to be anti-proteinase 3 antibody. Okay, that's done. So these are all about the ANCA-associated vasculitis. What about the immune complex vasculitis? We have only two things, isn't it? One is cryo and second is HSP. So as far as cryo is concerned, when you talk about cryoglobulinemia, think about hepatitis C virus. So in fact, 70% or 80% of cryo in the world right now is related to hepatitis C virus. In fact, the most common extrahepatic manifestation of cryo is, most common extrahepatic manifestation of hepatitis C virus is cryo. And what about HSP? When you talk about HSP, it's going to affect male children predominantly, okay, and along with it they tend to have a characteristic triad. So what is the characteristic triad? Patients tend to have GI involvement. So what do you mean by GI involvement? They're going to have abdominal pain, okay, they're going to have abdominal pain, and they can have melena, hematochezia, and even intussusception. Even that could be the clue in exam. And patients tend to have arthritis, and patients tend to have skin involvement. The typical skin involvement, everyone knows, it's palpable purpura. Even though palpable purpura can occur in plenty of other vasculitis, including ANCA-associated vasculitis, but in exam, think about HSP whenever they talk about palpable purpura. Another key point they will ask you is, these patients will have normal platelet. Why the examiner is asking this point again and again? Because we know that this purpura is not due to thrombocytopenia. This purpura is due to vasculitis. So that is the reason why they tend to ask. All of the following are characteristic features of HSP, except option C or D will be low platelets, and that's the right answer, because this purpura is not due to thrombocytopenia, rather this purpura is due to vasculitis itself. And plus or minus, these patients will have glomerulonephritis. And what is the type of glomerulonephritis they will have? They will have IJ deposits in the mesangium. Don't tell IJ nephropathy. IJ nephropathy is a different disease. Henoch-Schönlein nephritis is a different disease. So you have to say that these patients are going to have IJ deposits in the mesangium in case if they are going to have, okay, in case if they are going to have Henoch-Schönlein purpura. So this explains, okay, in a nutshell about all the vasculitis, right? So just like see this table and go before the exams. 100% I am sure you will be able to answer about each and every single vasculitis. I don't think they are going to ask any more details with regards to vasculitis. Okay, clear. So now only vasculitis that is pending is Behçet. Behçet is a different type of vasculitis because it's a multi-vessel vasculitis. Okay, it's a multi-system and multi-vessel vasculitis which can involve vessels of any size for that matters. That's the importance of Behçet syndrome. And Behçet syndrome is going to be typically associated with HLA-B5-1, or simply they can give HLA-B5. And what are the important features of Behçet? You're going to have aphthous ulcers. Okay, this aphthous ulcers can be oral aphthous ulcers or genital aphthous ulcers. Remember, oral aphthous ulcers is actually an essential requirement. Without recurrent oral aphthous ulcers, you will not be able to make a diagnosis of Behçet. So oral aphthous ulceration, that's very important. Plus or minus genital aphthous ulceration also. And patients tend to have skin involvement. Or more than skin involvement, we can say other features like eye involvement, so which is very, very important. When it comes to eye involvement, in the eye involvement, they are going to give posterior uveitis. Remember, till now we have been talking about anterior uveitis, but in Behçet, patients can have posterior uveitis, and because of the posterior uveitis, patients can have hypopyon formation. So whenever they give vasculitis with hypopyon, whenever they give vasculitis with posterior uveitis, answer will be Behçet. And patients will have venous involvement. Okay, venous involvement. So when I talk about venous involvement, it is DVT. So DVT is the most important. So any vasculitis with DVT. So any vasculitis can cause DVT, honestly speaking. But in exam, if they specifically mention DVT, first think about Behçet, then think about other vasculitis. So venous involvement, then skin involvement. The most common is erythema nodosum. So can anyone tell what is the importance of erythema nodosum in Behçet? Remember, erythema nodosum is a non-scarring lesion. Usually, erythema nodosum doesn't produce a scar, but very few causes of erythema nodosum can produce scar. One is Behçet. Behçet-related erythema nodosum can be a scarring lesion. Okay, that's the important point. So venous involvement, skin involvement, and finally, last but not the least, there will be a test called as pathergy test. Pathergy will be positive. So you know, pathergy means if you are going to give a small trauma in the skin, that area will become papular or pustular or nodular. So development of small papules, nodules, plus or minus pustules in the area of pinprick or trauma is what we call as pathergy. So pathergy is a quite specific test for Behçet. So HLA-B5, aphthous ulceration, eye involvement in the form of posterior uveitis, venous involvement, skin involvement, pathergy positivity. So these are the important features. Apart from that, CNS involvement can occur, cardiac involvement can occur, and retinal involvement can occur, and patients can have plenty of other features. Arthritis also can occur. So that is not important for exams. I have listed only the most important points that will be asked in exams with regards to Behçet. So this is done. So I think vasculitis is over. Now moving on to the next section. Okay, neurology. So neurology, only like 5-6 topics they tend to routinely ask. So Dr. Ashti Prajapati. So definitely this PDF will be shared. Don't worry. The previous session PDF, I'm trying to get out a good quality, but I'm not able to get a good quality PDF. So that is because I realized that I'm using a stacked model of slides. So that's why I'm not able to get a good quality. So I've tried my best after that multiple permutations and combinations. Now I'm sure that if I'm going to use this kind of individual slide model, the quality is good. So that's why I've shifted to this model. Hereafter for YouTube sessions, I'm not going to use a stacked slide model, for which I'm not able to get a good quality PDF. So don't worry about that. This PDF surely available. The next PDF I'll let you know. Okay. So once I get a good quality out of it. So important topics for FMGE. Dr. Shilpa, that's what we are doing. These are the important topics for FMGE. Honestly speaking, whatever topics I am discussing, okay, in this session are all basically things that are asked in the last 3 years exam. So I've carefully collected all the data from the last 3 years exam, okay, and I've compiled the top 50-55 topics for FMGE, and that is what I'm doing. So, and I've collected some from NEET PG also. So this is NB related topics. So that's why I'm saying this is the session for FMGE and NEET PG, and most importantly for FMGE. That's why we are doing this session in the first place. Otherwise, why should be the urgency to do the session today? I'd have done probably like next week, right? So I don't want to postpone to like next Saturday, because like FMGE's exam is coming by Jan 20. So before that, I have to finish it off. Okay. Let us move on. So let us start discussing about stroke. Okay. In stroke, the imaging is extremely important. So there are quite a few things they will ask you in stroke. So one is the stroke localization. Okay. First, you need to know the stroke localization. Then we'll move on to the stroke treatment, how to treat stroke. So what about the stroke localization? So point number 1, you need to know whether it's anterior or posterior circulation stroke. So anterior versus posterior. Anterior circulation stroke versus posterior circulation stroke. Anterior circulation stroke versus posterior circulation stroke. If it's an anterior circulation stroke, you're going to see certain characteristic features like hemiparesis. Okay, hemiparesis. And you'll be seeing visual field defects, VFDs. What do you mean by visual field defects? You can see homonymous hemianopia or quadrantanopia. And third, you might be able to see some cortical symptoms and signs like aphasia, agnosia and all. But most important here is aphasia. The Broca's and Wernicke's are the most important. So out of these 3, at least if you see 2, it indicates an anterior circulation stroke. But what about posterior circulation stroke? In posterior circulation stroke, usually you see syncope or loss of consciousness, or sometimes examiners may use the term drop attacks also. They are nothing but like kind of syncope only. Syncope, LOC, severe vertigo. I forgot that. So severe vertigo. Okay. So these are basically features of posterior circulation stroke. So after this, patients can also develop visual field defects in posterior circulation stroke. Apart from that, patients can also develop element type of cranial palsy. So this is a very important point. A stroke and having a lower motor neuron type. Okay, lower motor neuron type of cranial palsy. Always think about posterior circulation stroke. Whether hemiparesis can be there in posterior circulation stroke or not, answer is yes. Definitely it can be there. But according to the rule, if any one out of three is present, out of these 3, if just one is present, you can call it as a posterior circulation stroke. But when you want to diagnose anterior circulation stroke, you should have at least 2 out of 3. Minimum 2 out of 3 should be there to diagnose anterior circulation stroke. But just one out of these 3 criteria is enough to diagnose a posterior circulation stroke. You know what are the anterior circulation arteries? We have 3 arteries, right? So you're going to have the internal carotid artery, which is the mother of 2 important arteries, the MCA and the ACA. But everyone knows that the most common site of stroke is the MCA territory. MCA territory is the most common site of stroke. And posterior circulation means we are talking about the vertebro-basilar system, vertebral artery, basilar artery, and the posterior cerebral artery, PCA, posterior cerebral artery. So these are the arteries of the posterior circulation. These are the arteries of posterior circulation. So vertebral artery, basilar artery, and posterior cerebral artery, arteries of the posterior circulation. And another important thing they will ask you is, see, whatever arteries we have been discussing so far are basically large arteries. And these large vessels are going to divide into small vessels. Divide into small vessels. Divide into small vessels. So you need to know large vessel stroke versus a small vessel stroke. Small vessel stroke. How will you differentiate in exam? So you're going to have large vessel stroke versus a small vessel stroke. How will you differentiate between them? So whatever arteries we have spoken so far, these are all what? Basically large vessels. Everyone knows. But these vessels divide into small vessels. And how will you differentiate a large versus a small vessel stroke? So large vessel strokes generally tend to affect the cortex. Okay? Cortex. So that is why you're going to have the classic cortical signs and symptoms. So what are the cortical signs and symptoms? Whatever that starts with A, everyone knows that, right? So aphasia, agnosia, apraxia, acalculia. So these are all cortical symptoms and signs. But when you talk about small vessel stroke, these strokes are going to be subcortical strokes. They will not be cortical. So they're going to have no cortical symptoms and signs. Technically, they don't have cortical symptoms and signs. No cortical symptoms and signs, right? So this is the feature of subcortical stroke. For example, if they ask you stroke of the internal capsule, you won't have cortical symptoms and signs because the stroke is in the internal capsule, which is a subcortical region. And small vessel strokes are also referred to as lacuna strokes. You are correct. Many of you are correct. So these are also called as lacuna strokes. And there are plenty of different types of lacuna strokes. Pure motor, pure sensory, sensory motor, ataxic hemiparesis, and dysarthria clumsy hand syndrome. So don't worry about all those things. Just remember lacuna stroke. So why it's called lacuna stroke? Because after stroke, you will see small lacunes, small hypodense areas in the CT or probably even in the MRI, indicating a stroke in the subcortical region. So these are subcortical strokes, no cortical symptoms and signs. So examiner, if they specifically mention no aphasia, a stroke which is having a which is causing a upper limb and lower limb weakness, but no aphasia. They clearly give no aphasia. What will you diagnose? Subcortical stroke or a small vessel stroke, or otherwise called as a lacuna stroke. Hope you are clear. So specifically if they mention hemiparesis, no aphasia. Think about a subcortical stroke. So that's a clue that the examiner wants to give you. No cortical symptoms and signs, small vessel, subcortical, lacuna stroke. So this is one way of localization. So you know that each and everything has a lot of importance when it comes to stroke. For example, you need to know about the internal carotid artery. The most important feature is going to be the ipsilateral blindness. One eye is going to go for complete blindness if it's going to be an internal carotid artery stroke. That's an important point. Okay, so whenever the examiner mentions ipsilateral blindness or monocular blindness, the only stroke that can cause monocular blindness is ICS stroke, because you know ophthalmic artery is going to arise from the internal carotid artery. So middle cerebral artery involvement. Whenever there is a large large vessel involvement of the middle cerebral artery vessels, so you're going to have hemiparesis, but it's going to affect the upper limb and the face more than the lower limb. Upper limb and the face more than the lower limb. So the clue. So let me write. It's better, right? So if central carotid artery involvement, ipsilateral monocular blindness, that will be a very, very important clue for exams. And if it's a middle cerebral artery involvement, and if it's a large vessel involvement, not small vessel, if it's large vessel involvement, the patients will have hemiparesis, but that will involve arm and face more than the legs. That's very important. Feet will be gently spat. That is because of the arrangement of the motor homunculus in the cortex. So arm, face more than the legs. If it's an anterior cerebral artery involvement, patients can have hemiparesis, but leg involvement, leg and feet will be involved more than the arms and face. Okay, that is typical of ACA involvement. Or if it's an ACA large vessel involvement, patients can have other problems like gait apraxia. These are all exam questions. Gait apraxia, abulia, antisocial behavior. Okay, antisocial behavior. Release reflexes. What are release reflexes? Sucking reflex, rooting reflex, palmar grasp, plantar grasp. Okay, whatever reflexes that you have lost as a child. Lost as you grow up from the childhood. So those are called as release reflexes. Okay, so these are features of anterior cerebral artery involvement. So hemiparesis, leg involvement predominantly, like leg weakness more than the arm and face weakness, gait apraxia, abulia, antisocial behavior, release reflex. All these are features of anterior cerebral artery involvement. So quickly, what about posterior cerebral artery involvement? Coming to posterior circulation, whenever the patient is having posterior cerebral artery involvement, you need to know whether it's a P1 involvement or beyond P1, P2 involvement. If it's a P1 involvement, usually you tend to have midbrain and thalamic involvement. Midbrain and thalamus. Midbrain and thalamus will be involved if it's a P1 territory stroke. If it's a P2 territory stroke, then occipital lobe will be involved. If it's a P2 territory stroke, I'll repeat, occipital lobe will be involved. Occipital lobe will be involved. Occipital lobe will be involved. So if ipsilateral, okay, so if it's the stroke is unilateral. So if the P2 PCA stroke is unilateral, what you're going to get? You're going to get contralateral homonymous hemianopia, with macular sparing. That's a key point. With macular sparing. Contralateral homonymous hemianopia with macular sparing. Okay, that's the key point. So here the most important point is going to be the macular sparing. So that's the most important point. And if it's going to be bilateral PCA involvement, you're going to have something called as cortical blindness. If it's bilateral PCA involvement, you're going to have something called as cortical blindness. So what is cortical blindness? Otherwise called as Anton syndrome. This name we don't use it anymore, but you can call it as Anton syndrome. So here the patient will not be aware of his own blindness, because cortex is the one that gives you awareness. Okay, so if the cortex is damaged, you might not have awareness about the deficit that you have. For example, these patients can be blind, but they will deny their own blindness. It's not lying, but they don't know, they're not aware that they are blind. That's what you call as cortical blindness. That tends to occur in bilateral PCA infarcts or bilateral occipital lobe infarcts due to P2 PCA involvement. So PCA is done. And example of a P1 lesion. So what is the best example of a P1 lesion that tends to be asked in exams? Weber syndrome. So what is Weber syndrome? You're going to have ipsilateral third cranial nerve palsy. Ipsilateral third cranial nerve palsy. I told you, whenever you talk about posterior circulation stroke, cranial nerve involvement will always be LMN type. It will never be Yeoman type. So LMN cranial nerve palsy. So ipsilateral LMN type third cranial nerve involvement plus contralateral hemiparesis is what we refer to as Weber syndrome. Contralateral hemiparesis is what we call it as Weber syndrome. Okay, so fine. So that's an example. So PCA, okay, we'll wind it up. So what about the vertebral and basilar artery involvement? So whenever you have vertebral artery involvement, fine. So you're going to have a typical presentation, typical syndrome called as Wallenberg syndrome. Wallenberg syndrome, otherwise called as lateral medullary syndrome, LMS. So yes, Wallenberg syndrome is also called as pica syndrome. Remember, the first case of Wallenberg syndrome or lateral medullary syndrome was published by Wallenberg with the help of pica occlusion. So the first case was described with pica occlusion. That's why it's still called as pica syndrome. But the most common artery involved in pica syndrome is vertebral artery. Even though it's called pica syndrome, the most common artery is actually the vertebral artery. Okay. So what are the features of Wallenberg syndrome? Simple. You're going to have contralateral loss of pain and temperature in the body. Pain and temperature in the body and the limbs. Okay, that's because of ipsilateral spinothalamic tract involvement, and you're going to have ipsilateral loss of pain and temperature in the face. That is because of involvement of ipsilateral spinal nucleus of trigeminum. This is a revision class, so I'm not going to go into the details of anatomy. Just know the pointers, that's alone, it's enough. And patients can have ipsilateral Horner's syndrome. So ptosis, meiosis, anhidrosis, and loss of ciliospinal reflex and apparent enophthalmos. Those are the features of Horner's syndrome. And patients can have ipsilateral cerebellar symptoms. Ipsilateral cerebellar symptoms like ataxia, dysdiadochokinesia, okay, dysmetria, okay, dysarthria, cerebellar type of speech. And patients can have nystagmus, pendular knee jerk. So all these things will be ipsilateral cerebellar symptoms. Okay, and patients can have ipsilateral LMN type of, because whenever we talk about posterior circulation, LMN cranial nerve palsy, LMN type of cranial nerve 9th and 10th nerve palsy, plus or minus 11, because these are the lateral cranial nerves from the medulla that will be affected in lateral medullary syndrome. So 9 and 10 is more important. So 9 and 10 are basically the bulbar cranial nerves. So when these are affected, are going to result in dysphagia, dysarthria, dysphonia, poor voice production, and more importantly, these patients will have recurrent hiccups. This is a very, very important point. Many people will forget. So hiccups are a very, very important feature of lateral medullary syndrome. We have plenty of cases of lateral medullary syndrome. So even though it's not as common as the anterior circulation stroke, but every now and then we see one case of Wallenberg syndrome where the main complaint, in fact, will be the hiccups, recurrent hiccups, and intractable. Many times it will be very, very difficult to treat. So these are the features of Wallenberg syndrome. So whenever there is vertebral artery involvement, this will be the presentation. So whatever I told you. So you can see, all these are going to be the presenting features. And what about basilar artery involvement? So remember, you would have studied so many syndromes that are not important in practice, honestly speaking, and even for exams, it's a low yielding information. I don't know why students still stick on to the same thing. The Millard-Gubler syndrome, Fowell syndrome, it's a very low yielding information as far as exams are concerned. If you look at the past trend of exams, usually you don't get those syndromes that much, except Wallenberg syndrome. Wallenberg is very commonly asked in exam, but except Wallenberg, other syndromes like Millard-Gubler, Fowell's, Benedict syndrome, okay, then we have Northern-Agel, Claude syndrome, okay, then Raymond-Sestan syndrome, medial medullary syndrome, otherwise called as Digerin anterobulbar syndrome. So these are all very, very rarely asked and not a very high yielding information at all for your exams. I mean, I don't know, maybe the next exam they can ask, but till this time, okay, till this, I mean, last 3 years, they have not asked. But basilar artery, it's very important. Okay, somebody is asking, what do you mean by dense hemiplegia? So let me tell what is dense hemiplegia. So remember, I told you if it's a large vessel involvement. So these are large vessel, right? So these are large vessel involvement. In large vessel involvement, whenever MCA, ACA is involved, you have differential weakness, right? So arm and face is involved more than legs. Legs and feet are involved more than arms and face. Okay, legs and feet are involved more than arms and face. I'll repeat, you have a differential weakness. In MCA, ACA, large vessel involvement, your arms, face are involved more than legs, and legs and feet are involved more than arms and face, right, in ACA. But when you talk about subcortical strokes, especially if the stroke is in the internal capsule, I mean, that's classic, the stroke is in the internal capsule, there won't be this differential weakness. The leg involvement will be equal to arm involvement will be equivalent to face involvement. This is what we call as dense hemiparesis. I think people can understand what do you mean by dense hemiparesis. Leg equal to arm equal to face. This is dense. That's called as dense hemiparesis. Okay, so I think Dr. Roshan Raj is able to understand. So what is dense hemiparesis now? Okay. So what are the features of basilar artery involvement or basilar occlusion? So basilar occlusion will result in two important syndromes. One is called as locked-in syndrome. So locked-in syndrome will typically occur due to mid-basilar occlusions. Locked-in syndrome will be typically occurring in mid-basilar occlusions. And there's another syndrome called as basilar top syndrome. These are the syndromes that are commonly seen in practice. If at all basilar artery is involved, this is called as basilar top syndrome or top of basilar artery syndrome, where the top of the basilar artery, where it's going to bifurcate into two posterior cerebral arteries, is involved. So locked-in state, I'm not going to explain because everyone knows locked-in state. You'd have studied in the movies itself. So there is a movie called Munaba MBBS. It's a very famous movie. It's been translated into multiple different languages, including in Tamil, where we call it as Vasul Raja MBBS. I think it's been translated to many different languages. So in that movie, you have a character called as Anand Sir. You would have seen. So that is a typical locked-in case, where the patient will have quadriparesis, will be in the wheelchair. They cannot show facial expressions because of bilateral LMN, facial nerve palsy. The face will look like as if it's dead. And patients will have a complete horizontal gaze palsy. Okay? Why? Because pons is the center for horizontal gaze. The damage will be in the pons. That's the reason why they cannot move the eyeballs horizontally. But there will be limited vertical gaze movements. Vertical gaze will be limited. There's some vertical gaze will be intact because midbrain is the center for vertical gaze. So quadriparesis, can't express anything. So no facial expressions, can't move the limbs. Total loss of horizontal gaze. Okay, the patient will look as if they are dead and they are comatose, but they are not. These patients are conscious. Okay, and they can feel the pain, the sufferings that they can feel. Okay, so that's locked in state, which means they can see, they can hear, they can feel the touch, they can feel the pain, but they will not be able to express. It looks like as if the patient's soul is trapped in a dead body. That's what we call it as locked in state. Okay, conscious, able to feel everything. Even the pupils will react. Even that has been shown in the movie. If you see, pupils will react because of the anatomy. Sympathetic system is intact, parasympathetic system is intact. So pupils also will react. They can even blink, but all the voluntary movements will be lost. Can't show expressions, can't move a limb. That is locked in state. Basilar top will present in a very different way. So whenever the top of the basilar artery is involved, so you're going to have midbrain and a little bit of thalamic involvement. So midbrain will be involved and paramedian thalamus will be involved. Okay, paramedian thalamus. Yes, even in House MD, I don't know how many of you have seen the House MD. That's why I gave the example of the Munaba MBBS movie. But even in House MD, yes, one of the cases showed locked in state. So bilateral paramedian thalamus, bilateral medial midbrain. So you will involve the medial midbrain, and patients will have bilateral paramedian thalamus involvement. Okay, so that's typical of basilar top, because when the top of the basilar is involved, so that's going to affect the medial part of the midbrain, and above the midbrain you have thalamus. So the paramedian thalamus also will be involved. So this will result in a characteristic triad. So patients will have oculomotor problems. Why oculomotor problems? Because medial part of the midbrain is involved. Third nerve and fourth nerve can be involved. That's why oculomotor problems will be there. And patients can have altered mental status. Okay, patients can have altered mental status. And patients can have memory loss and hallucinations. Memory loss and memory issues and hallucinations. Okay, memory issues and hallucinations. So this is what we refer to as basilar top syndrome. Oculomotor problems, altered mental status, and visual defects, memory loss, hallucinations. So these are all characteristic features of top of basilar syndrome, basilar artery syndrome. So honestly speaking, to be honest, except the Weber syndrome and the Wallenberg syndrome, other things are not important. That is why I have exactly given what is relevant and what is not relevant. Okay, I have exactly given only things that are relevant in this slide. Whatever is not relevant, I have not mentioned at all. Okay, so if you are in a time crunch, don't study any other syndromes apart from this. It's totally killing time. It's a low yielding information. Maybe if they ask in this exam, next exam, I may not be able to tell the same thing. But as of now, only whatever I told you is important when it comes to stroke localization. I think you have learned about stroke localization. Now, how to treat a stroke? Even that is important, right? So, how are we going to treat? For FMG or NIT, again, my God, I'm getting the same question over and over again for FMG or NIT, FMG or NIT. I don't know why people are again thinking that FMG is different and NEET PG is different. I don't really understand that logic at all. Remember, basically both are like kind of same exams only because it's prepared by the same board. Okay, it's not prepared by a different board to call it as a different exam. Both are prepared by the same board only. Paper is going to come out from NBE and both are similar exams. I told you so many times. The only difference is FMG is qualification exam. NEET PG is a competitive exam. That's it. Nothing more than that. Okay, fine. So now coming to the treatment of stroke. So how do you treat a stroke? First of all, whenever a patient is present with acute focal neurological deficit, acute FND. Okay. So if it's an acute focal neurological deficit, you have to always suspect a stroke. Okay. And the next investigation that you're going to do is NCCT, non-contrast CT. So whenever the patient is presenting with acute focal neurological deficit, some deficit in the emergency, do NCCT. That's the next investigation. The idea of NCT is very, very different. So patient is having hemorrhage or patient is not having hemorrhage. That's all. The patient is having hemorrhage, you're going to follow hemorrhagic stroke pathway. Hemorrhagic stroke pathway. Somebody is telling fast. That's absolutely correct because in emergency, we don't have time to examine the patient in a detailed manner. We don't do that. So that's why we use something called as fast. Okay, currently we use a lot of other acronyms also. So including the eye movements and balance also. So that's different. So we're not going to talk about that right now. But anyway, fast means face, arm, speech, time. So currently we add the balance and the eye movements also to include the posterior circulation stroke features as well. But nevertheless, so quick assessment is more important. Okay, NCCT. If it's hemorrhage, you're going to follow hemorrhagic stroke pathway. If it's no hemorrhage, you're going to think about the possibility of ischemic stroke. You're going to make a likely diagnosis of ischemic stroke unless proved otherwise. So the next step is to ask yourself a question if the patient is having acute severe headache or not. This is a very important point in exam. Acute severe headache or not. So if at all they say acute severe headache, the next step will be to do a lumbar puncture. That's very important because here you are suspecting subarachnoid hemorrhage, acute severe headache. Patients telling thunderclap headache. Patients are going, if they say like patient is having like worst headache of life. So any acute severe headache, even if you have a suspicion of ischemic stroke, don't proceed any further. Proceed to LP here, even if the patient is having a normal NCCT. So next step, if the patient is not having acute severe headache, then you are going to think it as an ischemic stroke. Then you have to see whether the patient is eligible for thrombolysis or not. Eligible for thrombolysis or not. That's the next step, where the patient is eligible for thrombolysis or not. So if the patient is eligible for thrombolysis, eligible for thrombolysis, then you can perform thrombolysis in the CT room itself. Perform thrombolysis. There are two drugs that are approved so far. One is the IV TPA. TPA is nothing but alteplase. And second drug, that is tenecteplase. Even this can be used. But TPA is FDA approved. Tenecteplase is not yet FDA approved for stroke use, but you can use. It's approved in the trials. So TPA, that is alteplase. TPA is RTPA, recombinant TPA, that is alteplase. And second is tenecteplase. So isn't subarachnoid hemorrhage evident in NCCT itself? Yeah, that is the point that I want to say. Remember, 10% of subarachnoid hemorrhage can be negative in initial imaging. So 10% of subarachnoid hemorrhages can have a negative NCCT. So that is the reason we are proceeding to LP here, where you are trying to prove xanthochromia, the yellowish discoloration of the CSF. So what is the reason? 10% of subarachnoid hemorrhage can be having a negative NCCT. Okay, so I think I've replied that question. So anyway, so yes. So what do you mean by eligibility to thrombolysis? Eligibility to thrombolysis. So there are only two eligibility factors. One, there should be no contraindication to thrombolysis. So which means you need to study what are the contraindications given in Harrison. Just go and read. So if I list it out, it will be very difficult right now. So no contraindication to thrombolysis. Second, the window period, the last seen well time should be less than 4.5 hours. When it comes to stroke, we don't use the term window period anymore. We use the term LSW. That's called as last seen well time. Okay, LSW, last seen well time. So why use the term LSW? Because we don't know when the stroke has happened many times. Because MI will cause chest pain or some visible symptoms. But stroke will not cause pain. It will only cause deficit. If the patient is sleeping and if they got a stroke, we don't know when the stroke has happened. That's why in stroke, we cannot use the term window period. Rather, we use the term something called as LSW. That's called last seen dwell time. If it's within 4.5 hours, probably you can think it as an eligibility criteria for thrombolysis. So the patient is not eligible for thrombolysis, which means there are some contraindications, or if the patient is presenting beyond the LSW time, then probably you can do another investigation called as CT angiogram. This is a very important point. Similarly, even if you are performing thrombolysis, while performing thrombolysis itself, you need to perform CT angiogram, because in CT angiogram, you need to ask yourself a question whether the patient is having a large vessel occlusion or not. Large vessel occlusion. So what are the large vessels? Large vessels are nothing but the MCA, ICA, ACA, PCA, basilar, vertebral artery. These are all large vessels. Because whenever there is a large vessel occlusion, the patient may be eligible for mechanical thrombectomy. That's why. So in case if the patient is not having large vessel occlusion, then you are going to perform only standard medical care. Standard medical care. For example, there are plenty of medical care that should be given for a stroke patient, but you can start with aspirin. Aspirin or clopidogrel or both together. Aspirin and clopidogrel can be started. But make sure that antiplatelet should be started only after 24 hours of thrombolysis. Even this is a question. So after 24 hours of thrombolysis only, you have to start with antiplatelet agents. If you have thrombolyzed. If you are not thrombolyzed, then fine, you can start immediately. If you are thrombolizing the patient, then after 24 hours only, you have to start with antiplatelet. So in some situations, you can use aspirin, clopidogrel together. So that is too much for an undergraduate student. But nevertheless, you are starting either aspirin as a first choice. If the patient is not tolerating aspirin or some contraindication is there like peptic ulcer is, then you can go for clopidogrel also. If the patient is not having a large vessel occlusion, if the patient's large vessel is occluded, you are seeing some large vessel, large artery occlusion in the CT angiogram, then the next step is to see where the patient is presenting within 6 hours or not. Presenting within 6 hours. LSW within 6 hours or not. If the answer is no, okay, then you have to do an additional imaging called as CT perfusion imaging. Okay, CT perfusion imaging. Or if the patient is presenting within 6 hours, then check for eligibility for mechanical thrombectomy, eligibility for mechanical intervention. Mechanical intervention means currently we call endovascular therapy. EVT stands for endovascular therapy. EVT stands for, I'll repeat, endovascular therapy. The patient is eligible for endovascular therapy. Okay, then you can straight away do an endovascular treatment. Example, you can do mechanical thrombectomy. There are plenty of techniques. Simple example is mechanical thrombectomy. So thrombectomy devices are there, aspiration devices are there, rotablators are there. So I'm not planning to tell all those things right now. So what all we do is something that's different, but what you need to know for exams is different. So endovascular treatment, that they will ask you for sure. So if presenting within 6 hours, straight away you can proceed to endovascular therapy. If not presenting within 6 hours, you need to do CT perfusion imaging. In the CT perfusion imaging, if there is a mismatch, then only you can perform endovascular therapy, seeing the eligibility criteria. If the patient is having a mismatch, okay, if they are having a mismatch, then you have to proceed. If they're not having a mismatch, they're having no mismatch, then you have to proceed to standard medical care only. The patient is not having a mismatch in CT perfusion imaging. So if you're doing CT perfusion imaging, the idea is to find out the mismatch. If there is a mismatch, you can plan for endovascular therapy like mechanical thrombectomy. The patient doesn't have a mismatch, proceed to standard medical care. So the guideline will end there. That's all. The algorithm will end there. So what do you mean by mismatch? Now the big question is, what do you mean by mismatch? So that's why this image has been given. You all know that diffusion-weighted MRI is the most sensitive. Okay, diffusion-weighted MRI is most sensitive. Okay, and it's the one that's going to show earliest changes. Earliest changes in stroke will be shown by diffusion-weighted MRI only. Dr. Harsh is asking, how do we know if the clot is fibrin-rich or platelet-rich? No, we can't predict that. It's only like autopsy diagnosis. So based on autopsy reports, they have given that STEMI clots will be fibrin-rich and end-STEMI clots will be platelet-rich. So that's based on the data from autopsy, right? I mean, we don't need to basically. So autopsy data are there to help us understand what will be the pathology in most patients, so that it will guide us for the treatment. So whether thrombolysis will be effective or not. That's all. Otherwise, there's no way that we can find out whether it's fibrin rich or platelet rich without doing an autopsy. Anyway, so diffusion varied MRI is the most sensitive. Earliest changes in ischemic stroke will be visualized in diffusion varied MRI only. And what you are going to see in diffusion varied MRI is basically the infarct. Infarct, which means these are the dead areas. That's what I'm seeing in diffusion varied MRI. So whatever the whitish areas here are basically dead areas. And what about perfusion varied imaging? So in perfusion varied imaging, you are seeing the ischemic areas. Ischemia. So in perfusion varied imaging, what you are seeing is the ischemic areas. The ischemic zones is what you are seeing in the perfusion varied imaging. So whatever you are seeing here are the ischemic zones. Ischemic zones. So this is what we basically call as mismatch. You can see the amount of dead area is much less compared to the amount of area that is ischemic, which means you can say that so much of brain areas in this patient is alive but ischemic. Handwriting, please. See, my handwriting is, I feel it's okay, but I need to do faster. No, I have to finish faster. So we have plenty of things to finish. It's for your benefit only. If I'm writing one by one letter, then it's going to take plenty of time so that I'll not be able to finish as much as topics as I wanted to. So my idea will be to, you can pause the video later on. Once you're looking at the video later on, you can pause it and you can see one more time so that you can understand what I'm trying to say. So rather, if I'm going to write letter by letter in capital letters and all, so it's going to take plenty of time, which is going to be problem for you people only, because I wanted to give you as much as information as possible. So just adjust with me for today. So maybe from the next time onwards, I'll try to write it in capital letters. Nothing to worry. So what is going on here is ischemia. These are ischemic areas. These are areas that are ischemic, underperfused. It's not perfused. It's underperfused. Okay, but alive. And in these ischemic zones, there are some hidden dead areas. So that we have picked up by diffusion varied imaging. So what are the areas that are dead? But what are the areas that are ischemic and alive can be picked up by perfusion varied imaging. So now you can see there is a gross mismatch, which means in this patient there is a lot of salvageable area, which means these areas can still be salvaged. Okay. That is the whole reason for doing a CT perfusion imaging also. It's not just MR perfusion, even CT perfusion you can do the same. So once you find out that there are plenty of mismatch, so a lot of areas are still alive, waiting for help, you can perform endovascular therapy. So that's the rationale. Okay, now you can understand. So how to assess a patient with ischemic stroke and how to go about it. And another important thing they will ask you is ABC redo score. So this is a common score that they tend to ask in exam, ABC redo score. So this is for TIA, transient ischemic attack. So if you're suspecting a TIA, then probably you can do the ABC redo score. A stands for age more than 60. B stands for BP more than 140/90, that is hypertension. C stands for clinical features. So what are the clinical features? So if the patient is having speech disturbance alone, like dysarthria, weakness and all, only speech disturbance is going to carry 1 point. If the patient is having limb weakness as a history, that carries 2 points. And what about D2? D stands for diabetes mellitus, that carries 1 point, and duration of illness. Diabetes mellitus and duration of illness. Duration of illness means if it's 10 to 59 minutes, it carries 1 point. 60 minutes and above, it carries 2 points. So this is the ABCD score. Age more than 60, BP more than 140/90, these all carry 1 point. Clinical features, speech disturbance 1 point, weakness 2 points. D stands for diabetes 1 point, and duration of illness 10 to 59 minutes 1 point, and more than 60 minutes 2 points. So any score less than or equal to 3, we tend to call it as low risk of subsequent stroke. More than or equal to 4, high risk of subsequent stroke, which means within the next few days they can get a subsequent stroke. So what is the idea? You have to either admit the patient or not to admit the patient. Admit means we don't really admit, a short inpatient. In the ER itself you can observe and do MRI. If it's low risk, you can send the patient home and ask the patient to come next time and next day, and you can do an MRI. So less than or equal to 3, more than or equal to 4. That's going to tell you the risk. That's it. So that's for TIA. So I think the stroke area is pretty much over. Now going to subarachnoid hemorrhage. Only few things in subarachnoid hemorrhage are important. So the most important reason for subarachnoid hemorrhage is berry aneurysm. Remember, the most common cause is trauma, but berry aneurysms causing subarachnoid hemorrhage is important because this has a completely different line of management. That's why The aneurysmal SH is what you get in exam. But the most common cause of subarachnoid hemorrhage is not aneurysmal, it is traumatic. And how the patient will present if it's an aneurysmal SH, the most important feature is headache. And you know what will be the features of the headache. The headache will be of thunderclap quality, and they will tell it's the worst headache of life. These are the features they're going to give an exam, and the patients can have neck stiffness. Okay, that's very important point. Neck stiffness, and they can have altered mental status, AMS, altered mental status, and they can have focal neurological deficits. Usually cranial nerve palsy. Most commonly, they're going to have cranial nerve palsy. The most common cranial nerve to get affected is the 6th cranial nerve. In any subarachnoid hemorrhage, the most common cranial nerve to be affected is the 6th cranial nerve, CN6, abducens nerve. But if they specifically give ACOM aneurysms, anterocommunicating artery aneurysms, then optic chiasm can be involved. Optic chiasm can be involved. They specifically mention PCOM aneurysms, that is posterior communicating artery aneurysms. You can answer 3rd cranial nerve. So ACOM aneurysms, optic chiasm, PCOM aneurysms, 3rd cranial nerve. That's all. So this is the important point. But if they don't mention anything, then 6th cranial nerve will be the most common cranial nerve that will be involved in patients with subarachnoid hemorrhage because it has the longest subarachnoid course. That's why. And when you suspect, what is the investigation you are going to do? The first investigation is, of course, NCCT, non-contrast CT. In case if it's negative, you're going to do lumbar puncture. Lumbar puncture. Okay, because 10% of subarachnoid hemorrhage can be negative in NCCT. I told you already. So in case any of these investigations are positive, either NCCT showing subarachnoid hemorrhage or lumbar puncture showing xanthochromia, now you have to do CT angiogram. Or you have alternatives. Alternatives are MR angiogram. You can do digital subtraction angiogram, which is invasive angiogram. You can do anything. DSA is the gold standard because it's a direct catheter-based angiogram. But nevertheless, commonly what we perform in our setup is CT angiogram. That's what we perform. This is to locate where the aneurysm is. So in NCCT and LP, you will see the hemorrhage, but you cannot locate the aneurysm. To locate the aneurysm, you need an angiographic technique. So that's why we do CT angiogram. So treatment is very simple. Okay, you need to number one, you need to prevent rebleeding. So how will you prevent rebleeding? There are only 2 ways to prevent rebleeding. You have to do some procedure. One procedure is aneurysmal clip. This is what is very commonly performed in my hospital right now. But in selected cases, we can perform EVC. That's called endovascular coiling. So one is aneurysmal clip. Second is endovascular coiling. So this is to prevent rebleeding. Second, you have to reduce vasospasm risk. Vasospasm tend to occur from day 4 onwards. So for reducing vasospasm, you can use a calcium channel blocker called as nimodipine. In fact, nimodipine is exclusively approved for the sake of subarachnoid hemorrhage. It's not approved for any other investigation apart from any other disease apart from subarachnoid hemorrhage. Okay, so aneurysmal clip, endovascular coiling, and nimodipine. So this is the treatment that you need to know. So here is an example of an aneurysm. This is actually angiographic image, DSA image. Okay, of a ACOM aneurysm. The aneurysm is located in the anterocommunicating artery. This is the most common site. Okay, if they ask you which is the most common site of berry-aneurysm, the answer is going to be ACOM. So ACOM, this is the most common site. Okay, that's aneurysm. And same, this is an X-ray. So in the DSA, you can see again in a other view, you can see that the patient is having ACOM aneurysm. Okay, you can see here. All right. So going to the next one. So MS. MS is also a pretty much important topic. Okay. So MS, that is multiple sclerosis. And one of the important differential diagnosis for MS is going to be NMO, that is called as neuromyelitis optica. So what is the importance of MS? Okay, there are quite a few pointers that they can ask. So one is that this of females predominantly, and it's going to affect the temperate climates. Temperate climate. Somebody is asking mode of administration of nimodipine. Nimodipine is available both oral and IV. Depending on the patient's sensorium, you can use either oral nimodipine or even IV nimodipine. The usual dose of nimodipine is somewhere around 30 to 60 milligram. 4th to 6th hourly is what you're going to give. Okay. So anyways, fine. MS, that is multiple sclerosis, it's going to be a disease of females, and it's going to affect people in the temperate climate predominantly. It has a doubtful association with vitamin E deficiency. But when you talk about the clinical features, the most important is the feature, the dissemination in space and time. It's typically going to affect the white matter tracts, even though there is plenty of evidence to say that it can affect the gray matter also, but it typically tends to affect the white matter tracts, okay, in the brain and in the spinal cord. And when you talk about the clinical features, they will ask you the most common feature of multiple sclerosis. It's the sensory symptoms. I'll repeat, the sensory symptoms. They can have numbness, paresthesias. So that sensory symptoms are the most common in MS. And patients can develop optic neuritis. Optic neuritis. So this is the first presentation in almost 20% cases. 20% cases, optic neuritis is the first presentation. Which in fact, some MS cases, like around 20%, can present with optic neuritis. Okay, usually optic neuritis will be unilateral. Most commonly, when it comes to MS, optic neuritis will be unilateral, not be bilateral. That's the difference with the NMO, because NMO patients will have bilateral optic neuritis many times. And patients can have cerebellar symptoms. Cerebellar symptoms, okay? Cerebellar symptoms like ataxia. And there is a typical Charcot triad. You know that Charcot triad is also seen in something called cholangitis, where they will have fluctuating jaundice, abdominal pain, and fever. Okay, fever, abdominal pain, fluctuating jaundice. That's called Charcot's triad. And you have Reynolds pentad if you had altered mental status and other issues. So, but Charcot's triad is there for MS also. It's called SIN triad. What is SIN triad? Patients will have staccato or scanning speech. Okay, patients will have intentional tremors, and patients will have nystagmus. Patients will have nystagmus. This is the Charcot's triad of MS. Dr. Jean Charcot. Okay, she's the one who demonstrated the Charcot's triad in MS. Okay, cool. So cerebellar symptoms. Then, of course, internuclear ophthalmoplegia is another feature. Okay, that's an important feature. That's because of involvement of medial longitudinal fasciculus, MLF. And apart from that, they can have long tract signs. So what are the long tract signs? Corticospinal tract involvement. Okay, whatever the tracts that are passing down the spinal cord. But only myelinated tracts will be involved, usually. Myelinated tracts like posterior column and corticospinal tract. Poorly myelinated tracts like spinothalamic tract are very rarely involved in patients with multiple sclerosis. So long tract signs. So the long tracts that are going in the spinal cord, so they can be affected. So these are the characteristic features of MS. Sensory symptoms, optic neuritis, cerebellar symptoms, internuclear ophthalmoplegia, and long tract signs. So how will you diagnose? Diagnosis is based on something called as McDonald's criteria. McDonald's criteria. The criteria has been revised latest in 2020, I guess 2017 it's revised, and again 2020 it's revised. This is based on dissemination in space and dissemination in time. There is something called dissemination in space and dissemination in time. Intentional tremor means tremor on starting a movement? No, not tremor on starting the movement, especially when you are about to reach for an object. For example, if I'm going to take this AC remote, so during this time I will get the tremor. Okay, so this is intentional tremor, and that is the reason why many of the neurology textbooks have revised the terminology now. It's no longer intentional tremor, rather it is terminal tremor. So cerebellar patients will be mostly presenting with tremors, especially at the time when they are about to reach that object, because of the dysmetria and poor length coordination. Okay, that's why the other name for intentional tremors is also called as terminal tremors. So when you talk about McDonald's criteria, you have two things. One is dissemination in space and second is dissemination in time. So what do you mean by dissemination in space? You're going to diagnose through radiology. Clinically also you can determine both dissemination in space and dissemination in time, but MRI is going to tell you the clue. MRI with gadolinium contrast. So this is the gold standard investigation. If they ask you investigation of choice or gold standard investigation, okay, that is MRI with gadolinium contrast. Okay, what is dissemination in space? Number one, you should have at least two. Okay, I'll repeat. Sorry, dissemination in space means you should have at least two lesions in the brain in MS specific areas. MS specific areas. MS specific areas. At least two lesions in MS specific areas. What are the MS specific areas? Juxtacortical. I'm not telling subcortical. Don't use the term subcortical. It is juxtacortical. Second, you can see in the brainstem. Okay. Third is the periventricular region. Periventricular region. Fourth is the spinal cord. These are the most important MS specific regions. And even corpus callosum. because corpus callosum, if you want, you can write, because corpus callosum is also periventricular. Corpus callosum. So these are the MS specific areas: juxtacortical, brainstem, periventricular, subspinal cord, corpus callosum. These are MS specific areas. You should have at least 2 lesions, okay, in MS specific areas. And number 2, I mean, this is dissemination space. That's correct. That's done. Dissemination space is done. And what is dissemination in time according to MRI? Okay, so you should have 2 different lesions occurring in different points of time. For example, if you have a new lesion, which means already you are having an old lesion, on top of that, see, infratemporal means brainstem. That's what I'm talking. Infratemporal. Brainstem lesions are nothing but infratemporal lesions. Somebody is commenting infratemporal. That's nothing but brainstem lesions. Infratemporal. Brainstem cerebellar. Infratemporal. So dissemination in time. So what do you mean by dissemination in time? So new lesions. New enhancing lesions. New enhancing lesions. Okay. Or alternatively, new T2 flare lesions. New T2 flare lesions. Okay. So, which means already there's an old lesion. On top of that, you're getting a new lesion, which means it's the dissemination in time. Second, number 2, if you're having simultaneous enhancing and non-enhancing lesions. Simultaneous enhancing and non-enhancing lesions. Even this is an example of a dissemination in time, which means these enhancing lesions are basically new lesions. Non-enhancing lesions are basically old lesions. Okay, so this is dissemination in time. The most important thing that you need to know is they have added the 3rd criteria in the 2020 revised McDonald's criteria, that is presence of CSF oligoclonal bands. CSF OCB positivity. CSF oligoclonal bands will be positive. That's the 3rd new criteria that I've added in the revised McDonald's criteria. So many people can ask, what is its relationship with dissemination in time? Honestly speaking, it has no relationship with dissemination in time. But this is added only to improve the sensitivity of the criteria. I'll repeat, CSF oligoclonal bands positivity is not at all related to dissemination in time. But this is added in the revised criteria just to improve the sensitivity of the criteria for diagnosis. That's why this is a new thing that's been added in the dissemination in time. Okay, that is CSF oligoclonal bands. That will be positive. And it's a very sensitive investigation for MS. So if you have combination of dissemination in space and dissemination in time, at least one of the features are there, it is equivalent to multiple sclerosis. That's how you make a diagnosis. Dissemination in space plus time. So what is the gold standard imaging? MRI with gadolinium contrast. But most patients will have CSF oligoclonal bands also, but this is a sensitive investigation, but it is not a specific investigation. It's a poorly specific investigation. Okay, MS. This is how you diagnose MS. Okay, fine. So look at this lesion. This is a typical MS lesion, very commonly asked in exam. Okay, so this is the old lesion. Okay, how they will look like in T1? They look like black holes. These are called as T1 black holes. Old lesions, non-enhancing. They won't enhance. This is our new lesion presence. This is a new lesion. Same T1 varied imaging with contrast, it will enhance. Most of the new lesions will be unilateral. They won't be bilateral. Most of the lesions will be on one side. It will be a single lesion usually, many times one lesion. That's characteristic of MS. And they tend to have a typical open ring kind of enhancement. Okay. So remember, ring enhancing lesion means fully ring enhancing. That is not typical of MS. You have different DDs for ring enhancing lesions. MS patients will have open ring enhancement like what I've shown you. That's typical of MS. Okay. And they tend to have optic neuritis. Remember, many people know that for optic neuritis, the gold standard is VEP. That is visual evoked potential. But MRI is a very, very, very good alternative investigation for patients with optic neuritis, where you can see optic nerve edema, enhancement of the optic nerve. And in MS, usually optic neuritis will be unilateral, like what you see here. So these are the typical MS lesions. And you can see this is a periventricular lesion that you're seeing here. Here you are seeing a juxtacortical lesion. Juxtacortical lesion here. That's what you're seeing here. And here you are seeing optic neuritis, optic nerve enhancement. Okay, these are all T1 weighted images. Okay, except for the optic nerve, that's a T2. The first two are basically T1 weighted imaging. Okay, with gadolinium contrast. Enhancement is there or not. So this is typical MS. What about NMO? NMO spectrum disorder. NMO. So NMO patients, okay, number one, will be having optic neuritis. I mean, first of all, clinical features are very important. So we have something called as core clinical features I'll tell you what are the core clinical features. Number 1. Second, they can have antibody positivity. Antibody positivity. So MS don't have antibodies. So far, even though the IgG levels in the CSF will be increased in MS. I'll repeat, IgG levels in the CSF will be increased in patients with MS. But there is no single antibody that's been proven to be positive in MS. Okay, no single antibody. But in NMO spectrum disorder, antibody may be positive. What is the antibody? Anti-NMO IgG antibody. Anti-NMO IgG antibody. This may be or may not be positive. Anti-NMO IgG antibody, otherwise called as anti-aquaporin 4 antibodies. Anti-aquaporin 4 antibodies. Anti-NMO IgG antibody or anti-aquaporin 4 antibodies. Number 3. You have to rule out alternative causes. You have to rule out alternative causes. This is NMOST. You have to rule out alternative causes. Core clinical features along with that antibody positivity and rule out alternative causes. So what are the core clinical features? What are the core clinical features? So core clinical features means number 1, optic neuritis. Often it will be bilateral. Most oftenly it will be bilateral. Bilateral optic neuritis. In MS it will be usually unilateral. And second, spinal cord involvement. And spinal cord involvement will be extensive. Longitudinal extensive transverse myelitis. That's what we call LETM. I'll repeat, LETM stands for longitudinal extensive transverse myelitis. At least 3 different segments of the spinal cord will be involved. At least 3 segments of the spinal cord will be involved. In MS, even though there is a spinal cord involvement, I told you so many times, even though there is a spinal cord involvement, it will never be complete. It will be only a partial transverse myelitis. Only partial involvement will be there. Partial transverse myelitis. And only less than 3 segments will be involved. It will never be LETM. LETM is never a feature of MS. It won't involve. And in MS, peripheral cord will be involved. Peripheral and dorsal cord. Okay? Peripheral and dorsal cord will be involved. Peripheral, dorsal. Peripheral, dorsal. Peripheral, dorsal. That is MS. Posterior, periphery. That is MS. But in NMO patients, central cord. Okay? Central cord will be involved. Central. Okay? That's the important point. Number 3, patients can have brainstem involvement, especially area postrema involvement. Area postrema involvement where the patient can present with severe nausea, vomiting and hiccups. That could be the feature of NMOST. Nausea, vomiting, hiccups. Nausea, vomiting, hiccups. Okay, area postrema syndrome. Number 4, patients can have diencephalic involvement. Diencephalon can be involved. That can be, this is rare but possible. And finally, cerebral cortex. Cerebral cortex. Okay. Remember, the first 3 are common. First 3 are actually common. The other 2 are rare. Okay. These are the core clinical features of NMOST. So, along with core clinical features, if you have antibody positivity and once you rule out alternative causes, you can make a diagnosis of NMO spectrum disorder. In that, most important for NEET PG and FMGE exam is going to be the antibody positivity, the anti-aquaporin 4 antibody. That is otherwise called as anti-NMO IgG antibody. So this is a high yielding point in exam. When we talk about NMO. Okay, cool. So this is MS and NMO. Done. So next, coming to myasthenia gravis. Again, another important point that they tend to ask in exam. So what are the key features of myasthenia gravis? Number 1. So they will tell something called as fluctuating weakness. Okay. Fluctuating weakness. If they use the term fluctuating weakness, that is a very, very important point. And where will be the weakness? The weakness will be typically proximal weakness. Okay. Proximal weakness, comparator of distal weakness. And another key factor to tell it's myasthenia gravis in exam is the diurnal variation of weakness. Okay. Patients can have diurnal variation of weakness. Okay. Fluctuating weakness and it will be diurnal in nature. And along with that, if you look at the other key clinical features, patients will have ocular involvement. Okay. Number 2, patients will have normal tone. If there is a limb involvement, patients will have normal tone. I will write here itself. If the fluctuating weakness, patients will have normal tone. Okay. Patients will have normal reflexes, deep tendon reflexes will be normal. And patients will have no bladder bowel involvement. This is a very, very important point because its counterpart LEMS, that is Lambert-Eaton myasthenic syndrome, will have bladder bowel involvement. So Myasthenia gravis is a pure skeletal muscle problem. It doesn't involve smooth muscle, so no bladder bowel involvement, no cardiac involvement. Okay, normal deep tendon reflexes. Okay, and finally, patients tend to have normal plantar, so there will be no Babinski. Babinski will be negative. Babinski negative. Okay, these are the key features of myasthenia gravis. And number 2, ocular weakness. Ocular weakness occurs in almost all patients. This is 100%. Okay, every single patient will have ocular weakness. And the most common feature of ocular weakness is ptosis. Diplopia will be there, but most commonly it is ptosis. That is ocular weakness. So what are the key points? Normal tone, normal DTS, normal bladder and bowel, Babinski negative, normal plantar, ocular involvement, most commonly ptosis. They can have diplopia and ophthalmoplegia, that's fine. No bladder bowel, no cardiac. Okay, no smooth muscle involvement. That's a very important point. Okay, so key features are done. So how will you diagnose? If they ask you the most sensitive investigation, it is single fiber EMG. This is only theoretical, but we don't perform in practice. That's called single fiber EMG, SFEMG. That's more sensitive but not specific. If they ask you the most specific investigation, answer is antibodies. There are plenty of antibodies. Acetylcholine receptor antibody, you have anti-MuSK antibody, muscle specific kinase antibody, and you have anti-LRP4 antibody. Yes, somebody is telling correctly. So diurnal variation means these patients will have more weakness as the day progresses. Towards the evening times and all, they will have more weakness. So that is what we call it as diurnal variation. In LEMS patients, yes, correct. So they will improve as the day progresses. Here the patient will get more weaker as the day progresses. Acetylcholine receptor antibody, anti-MuSK antibody, and you have something called anti-LRP4 antibody. 70% patients will have acetylcholine receptor antibody, 15% of the time they'll have anti-MuSK, and 4% of the times anti-LRP4. Remaining 11% of the times they may or may not have antibody, but usually there will be some antibody, but it is not commercially available for testing. So there is no true seronegative myasthenia gravis. There will be some antibody, but commercially we are not testing, that's all. So basically myasthenia gravis is a type 2 hypersensitivity reaction because it's predominantly because of antibodies, nothing more than that. So if you do RNS, but they will ask you another point, if you do something called repetitive nerve stimulation, you're going to see something called decremental response. Why this is important? Because in another disorder called as LEMS, there will be something called as incremental response. That's why that point is important. Decremental response with myasthenia gravis. And one of the important clinical tests that they can ask is something called as IcePack test. Heterophonium test is no longer used in clinical practice. Really, if you ask me, there is no hospital that does heterophonium test, even though that's a traditional test described in all pharmacology textbooks and in some medicine textbooks also it's given. But clinically, we don't use the test at all in practice. It's not available anywhere in India. But this test is very important. Rather, we have something called as IcePack test. So this patient is one of our patients where you can see that before the application of the IcePack, you can see the ptosis over here. And after the application of IcePack, the ptosis improves. Why this is important? Because this is one of the excellent tests for diagnosing myasthenia gravis. It has a sensitivity and specificity like as good as your nerve conduction study in EMG. So that is the reason why this is a very, very important test for exam. That's called as IcePack test. It's a very important clinical test. Okay, so this is all about myasthenia gravis that you need to know. So treatment, most of the time they won't ask. You can use pyridostigmine, and thymectomy also can be used. And remember, 15% of myasthenia gravis patients will have thymoma. 15% of myasthenia gravis patients will have thymoma, which means myasthenia gravis can be a paraneoplastic syndrome with an underlying thymoma. In exam, how will you suspect if you have an anterior mediastinal mass with myasthenia gravis features? Suspect thymoma. Suspect myasthenia gravis. If they give a hilar mass, okay, then think about Lambert-Eaton myasthenic syndrome because small cell lung cancer is associated with anti-voltage gated calcium channel antibodies, that is called as LEMS, Lambert-Eaton myasthenic syndrome. But in myasthenia gravis, usually it will be anterior mediastinal mass. That's indicative of thymoma. Okay. So another important gold standpoint that you need to know is thymectomy can be used only for patients with thymoma or not even without patients with thymoma. Thymectomy can be used in patients even without thymoma. In selected patients, you can use thymectomy as a treatment option even if they don't have a documented thymoma, because thymic abnormality is very common in myasthenia gravis patients, and even without thymoma you can consider thymectomy in certain patients. But it asks you first line treatment pyridostigmine for most patients. Okay. Another important question that you may get in exams is GPS, that is Guillain-Barré syndrome. So if you want to explain Guillain-Barré syndrome in one sentence, how will you explain? It's an acute, ascending, areflexic, flaccid, quadriparesis. Quadriparesis. Dr. Soumya, I told already that thymic hyperplasia will be seen in 85% plus patients. That's why I told you even without thymoma, you can do thymectomy. But how can you prove thymic hyperplasia? The thymus gland in imaging can be normal or abnormal. But that's why selection of patients is little difficult, little tricky over there. But so that's why I told you even without frank thymoma, you can do thymectomy in patients with myasthenia gravis, which can be beneficial. So how will you describe GBS? GBS is nothing but acute ascending areflexic flaccid quadriparesis. That's it. So it's an acute illness. So it occurs within days usually or within weeks, but usually within days, and ascending, which means it starts in the legs and then goes up. Areflexic, the DTRs will be lost. The deep tendon reflexes will be lost, even though Babinski can be negative. Plantar will be flexor only, but DTRs will be lost. Flaccid, which means the patient will have flaccid weakness, not a spastic weakness, quadriparesis over a period of time. So this is the typical feature of GBS. And around 65% patients will have history of diarrhea or URI. They'll have either history of diarrhea or URI, which means it will be usually due to after some infection. In 2/3 of the patients, it will be usually due to some infection. So 1 week or 2 weeks prior, they will have history of diarrhea or URI. That's very common. And what is the most common cranial nerve that is affected in GBS? If they ask you the most common cranial nerve that is affected in GBS, answer is 7th cranial nerve. And often it can be bilateral, like what you see here. So here is a patient who is having a bilateral Bell's phenomenon. So this is the bilateral Bell's phenomenon. Whenever you have a Bell's phenomenon, it indicates a element type 7th nerve palsy. Here the patient is having bilateral Bell's, indicating a bilateral element type cranial nerve 7 palsy. It can occur in patients with GBS. Most common cranial nerve, 7th cranial nerve in GBS. Okay, so what are the investigations? If you suspect, what are the investigations you're going to do? So one is CSF analysis and second is nerve conduction study. So both can be normal initially. So a normal CSF and normal NCS doesn't rule out GBS, and you have to start treatment no matter what if you suspect. But what you see in NCS, you will see demyelinating pattern, a multifocal demyelination. That's what you see in typical GBS. And in CSF, you're going to see something called as albuminocytological dissociation. Albuminocytological dissociation, which means you'll have increased proteins. Usually whenever there are increased proteins, you'll have increased number of cells also. But in patients with GBS, you're going to have normal number of cells, which means it will be less than 5 to 10, not more than that. Normal CSF contains less than 5 cells, all of which will be lymphocytes. So typically in a GBS patient, it will be less than 5 to 10. Anything more than 50, rule out GBS. It's unlikely. Anything more than 50, rule out GBS. So increased protein, normal cells. This is what we call as albuminocytological dissociation. So two key features: demyelination NCS, albuminocytological dissociation CSF. That are the pointers towards GBS. And treatment, most important thing is no steroids. I told you in many of my previous classes, in 3 conditions, don't use steroids. One is GBS, second is going to be scleroderma, third is going to be your IPF, idiopathic pulmonary fibrosis. In these 3 conditions, the exam don't answer steroids. It will be definitely wrong. So what are you going to use? You are going to use either IVIG or plasma exchange. Use any one only. Don't use both. Either IVIG or plasma exchange. Don't use both. And there is a variant of GBS called as Miller-Fisher syndrome. There's a variant of GBS that's called as Miller-Fisher syndrome. It's going to present with a typical triad of areflexia, ophthalmoplegia, and ataxia. Areflexia, ophthalmoplegia, and ataxia. This is the triad of Miller-Fisher syndrome associated with an antibody called as anti-GQ1B antibody. Anti-GQ1B antibody. So that's also a variant of GBS. That's called as Miller-Fisher syndrome. Ataxia, areflexia, ophthalmoplegia. And if they ask you the most common cranial nerve involved in Miller-Fisher syndrome, then answer will be cranial nerve number 6. So if they ask you specifically Miller-Fisher syndrome, then the most common cranial nerve will be cranial nerve number 6. Otherwise, the most common cranial nerve involved in GBS is cranial nerve number 7 only. And remember, GBS is also called as AIDP. It's called as acute inflammatory demyelinating polyradiculoneuropathy. Acute inflammatory demyelinating polyradiculoneuropathy. Okay. Then coming to some important muscular dystrophies. I think in the last 3 years of FMGE exams, two times they have asked the muscular dystrophies. So I know what the picture shows. The child is actually showing something called as Gower sign positivity. So that's what the child is showing here. And the 2 most important muscular dystrophies are Duchenne muscular dystrophy and Becker muscular dystrophy. At least this thing you need to know for exam. So both Duchenne and Becker have some common features. What are the common features between Duchenne and Becker? So it is due to mutations in the dystrophin gene, one of the largest genes that you can ever see, dystrophin gene, and there will be defective dystrophin protein, and both are X-linked recessive disorders, which means it's going to typically affect males, and females will be carriers. And both of these patients will be having proximal weakness, and at one point of time they will end up with a wheelchair, both of these patients. There's no doubt about that. And both of them can have cardiac involvement. Both of the patients can have additional cardiac involvement in the form of cardiomyopathies. Both of them can have cardiac involvement and cardiomyopathies. These are some of the common features. But what are the differentiating features? The onset is very important. Onset. When you notice, the onset is going to be within 2 to 5 years. Within 2 to 5 years itself, you'll be able to see the features of Duchenne. But Becker's, the onset will be beyond 10 to 12 years. It will take a little longer for Becker's muscular dystrophy. And when the patient will become wheelchair bound. So by around 10 to 12 years mark, these patients will become wheelchair bound. This is a very important clue in exam. By the time Becker start presenting, if it's a Duchenne, the patient will be already in the wheelchair by 10 to 12 years. And usually death occurs by around 20 years. By around 20 years, they will die. The most common reason for death is respiratory failure, diaphragmatic palsy, respiratory failure. Most common reason. And remember, if it's a Duchenne muscular dystrophy, the muscle weakness will always be first, then only they will develop cardiac involvement. If at all they develop cardiac involvement, cardiomyopathy, weakness is always the first, then only they will develop cardiac involvement. But in Becker, in some patients, cardiac involvement may be first. I'm telling may. It's not always. May have cardiac involvement first, even before the onset of muscle weakness. This is actually a point that was given in one of the NEET PG exams in the past. So, some patients with Becker muscular dystrophy can have cardiac involvement first. Okay, can have cardiac involvement first. After that, they can develop limb weakness. And usually, they will become wheelchair bound after 30 years only. Till that, they will be ambulant only. And the death will be in the 40s generally. 40s or probably in the 50s. So, death doesn't occur before the 40s. Usually, in the 40s only, they die. One of the important reasons for death in patients with Becker's muscular dystrophy is going to be cardiomyopathy also. And in some patients with Becker's, cardiac involvement can precede your muscle weakness. That's an important point. So, some people are commenting on calf hypertrophy. Most common cause of death in patients with Duchenne is definitely respiratory failure. Second important cause is cardiac failure. In Becker, we don't have data. That's the problem. Becker is a very rare disease. It's a mild form of the disease. We don't have data, sufficient data. So, some patients can die of cardiomyopathy and some patients can die of respiratory failure also. And what about this thing? Other common features. Some people are commenting on calf pseudohypertrophy. Yes, that's a common feature of both, right? So, that can be seen in both. That doesn't separate anything. And both patients can have Gower sign. Gower sign can be seen in both. So, these all doesn't separate whether it is Duchenne or whether it is Becker. Okay, fine. So, the two important muscular dystrophies are also over. Then we can move on to other important topics, like for example, oncologic emergencies. When you talk about oncologic emergencies, the most important oncologic emergency is tumor lysis syndrome. Okay. So, tumor lysis syndrome tends to occur predominantly in hematological malignancies. Hematological malignancies, especially high-grade hematological malignancies. Especially high-grade hematological malignancies. That's where you're going to get tumor lysis syndrome. What do you mean by high grade? The best examples will be Burkitt's lymphoma, and the best another best example probably will be DLBCL. But literally any hematological malignancy can cause that. Okay, but the most important are going to be Burkitt's and DLBCL. But it can occur with AML, acute myeloid leukemia with very high counts, or it can occur with patients with acute lymphoid leukemia, lymphoblastic leukemia with high counts also. Possible, but it's always hematological. Very, very rarely with solid organ tumors. Solid organ tumors usually does not cause tumor lysis syndrome. Very, very rare. Very rare. And certain cancers have very low risk. And again, there is high risk and low risk. For example, if you have Burkitt's or DLBCL, it's a high risk tumor. But if you look at multiple myeloma, Hodgkin lymphoma and all, they are low risk tumors. So you can categorize further into high risk versus low risk. Anyway, so what are the features of tumor lysis syndrome? So there are two types of tumor lysis. One is LTLS, that is laboratory tumor lysis syndrome, and second is CTLS, that is clinical tumor lysis syndrome. So what is laboratory tumor lysis syndrome? You have the characteristic laboratory features like hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia. Okay, so these are the typical laboratory findings of a LTLS, that is laboratory tumor lysis syndrome. So these electrolyte abnormalities will result in some clinical features, like for example, acute kidney injury. That becomes a clinical TLS, AKI. And second is seizures because of hypocalcemia, arrhythmias because of hyperkalemia and hypocalcemia. So this is called as CTLS or clinical tumor lysis. How do you treat tumor lysis? First, prophylaxis. They will ask you prophylaxis. What prophylaxis you can use? So number one, hydration. Adequate IV fluids are very, very important to prevent the development of tumor lysis when you start any chemotherapy. Plus, you have to start with either allopurinol or rasburicase. Depending on the risk, you can start any one. If the patient is at low risk or intermediate risk, you can start with allopurinol, or alternative will be febuxostat. Both are xanthine oxidase inhibitors. If you want to give recombinant uricase, you can use rasburicase also. So in high risk patients, you can prefer rasburicase. Remember, rasburicase is contraindicated in G6PD. G6PD deficiency. Rasburicase and pegloticase both are contraindicated, but pegloticase is not approved in patients with tumor lysis. Only rasburicase is approved. Rasburicase though is contraindicated in patients with G6PD deficiency. And what is the treatment? So once you know that the patient has developed tumor lysis syndrome, IV fluids are very, very important to prevent the precipitation of monosodium urate and calcium phosphate crystals. That's correct. IV fluids are very important. Then apart from that, you have to start with rasburicase, especially once the patient develops clinical tumor lysis syndrome. There is no turning back. You have to start with rasburicase only. Allopurinol is not effective for treatment of tumor lysis. Only rasburicase should be used to rapidly lower the uric acid levels, and plus or minus renal replacement therapy. If the patient is having severe problems, then RRT, renal replacement therapy, should be tried, which is nothing but dialysis. One thing that was followed in the past, which we don't use it right now, is urinary alkalization. Don't do that. So previously it was being done in the past, like 10 years ago, 15 years ago, they tend to alkalize the urine to increase the elimination of uric acid in the urine. But right now we don't do, because there are a lot of controversial evidence which says that urinary alkalization can increase the crystallization of calcium phosphate crystals that can cause more damage to the kidneys. So don't do that. Urinary alkalization is something that's not tried in the current era. IV fluid, rasburicase, dialysis, that's all in severe cases. It's a very, very important oncological emergency. And another important oncological emergency is SVC syndrome. Okay, these are two things I'm going to discuss right now. Other things are not important for you. That is superior vena cava syndrome. So usually it will be due to some tumor. I mean, you can even think about retrosternal goiter also. Literally anything in the mediastinum can cause SVC syndrome. But the most common cause is non-small cell lung cancer. But it could be small cell lung cancer, it could be thymoma, it could be mediastinal lymphoma, it could be retrosternal goiter, it could be anything. But non-small cell lung cancer is the most common cause of SVC syndrome, compression of SVC. And what will be the clinical features? In exam, when will you suspect? Suspect when the patient is having neck edema, neck and face edema, neck, face and arm edema. This is the key feature. Neck, face and arm edema, key feature. Any cancer patient who is having mediastinal tumor, having a neck, face and arm edema, it is SVC syndrome. Plus or minus patients can have dilated chest veins, dilated chest veins, dilated chest veins. Plus or minus patients can have severe symptoms like shortness of breath, hypotension, okay, headache and altered mental status. These are all severe symptoms of SVC symptoms. These are all severe symptoms of SVC syndrome. For an exam, they may not give severe symptoms. They may just tell a patient with mediastinal tumor and presenting with neck, arm and face edema. That is characteristic of SVC syndrome. Yes, there will be facial plethora because of the congestion, but the edema is the most important. Okay. So if you suspect SVC syndrome, what is the investigation of choice? If they ask you investigation of choice, CECT of the chest, or specifically CT venography of the chest, but just write CECT of the chest and give CECT of the thorax. Okay, so that's the investigation of choice. So how will you treat in case if the patients are having severe symptoms? In case if the patients are having severe symptoms, proceed to stenting. Okay, you have to do SVC stenting. You can do a catheter venography of the superior vena cava and proceed with stenting. That's all. If non-severe, If the patient is having not so severe SV syndrome, just treated with like standard therapy for cancer. Treatment of cancer alone is enough. Like for example, you can use a chemotherapy or radiotherapy depending on what is the type of cancer that you're dealing with. And after this, maybe in some cancers, you may need to proceed with stenting, but it depends. Okay, in some cases, high-risk patients, you can proceed with stenting, but okay, in non-severe cases, the treatment of cancer is more important. That's all. So this is what you need to know with regards to SV syndrome. So oncological emergencies are done. Now coming to hematology part. In hematology, you all know like there are very few things that are important from medicine perspective. So you would have studied extensively about hematology from pathology and all. But one thing I would tell about hematology in NEET, PG and FMGE exams is the fact that the questions will be very simple. And many students tend to read extensively with regards to the cytology, slides, this, that and all. But trust me, when it comes to FMGE and NEET exams, the hematology part questions will be very, very simple. And most of the questions will be extremely straightforward. And they don't tend to ask any complicated pathology question. I mean, complicated slide related questions or complicated cytology related questions and all. So no need to think too much about that. If you like our channel, please subscribe. And let me tell you the important features of multiple myeloma. Hematology is scary. Why hematology is scary? I don't understand. For what reason you are telling it is scary? So there's no reason to get scared of hematology in the first place. So it's actually quite an easy topic. Usually, I told you, the FMG and NEET PG exam questions will be extremely simple and straightforward. Okay, so let me come back to the discussion. So what you're seeing here is the myeloma cells. These are the cancer cells in a patient with multiple myeloma, and these are the lytic lesions in the skull. So this is the same picture that they asked in like twice in FMG exam. I think, in fact, 3 times, same picture. I think 2020, June, 2021, June, and even in 2021, December also they asked, I guess. So 3 times they asked the same exam. I mean, same question. So the lytic lesions in the skull. So this is multiple myeloma. So what are the difference between the 3 things? Okay, so in exam they will ask you. So one, you have something called as MGUS, that is called as monoclonal gammopathy of undetermined significance. Next one is smoldering multiple myeloma, otherwise called as asymptomatic multiple myeloma. Then third one is you have multiple myeloma as such, that's a symptomatic myeloma. And finally, last but not the least, we have something called plasmacytoma. Plasmacytoma. So MGUS, monoclonal gammopathy of undetermined significance, smoldering or asymptomatic multiple myeloma. Third is multiple myeloma. Fourth is plasmacytoma. So how will you differentiate each and everything? So first you need to know bone marrow plasma cells. Okay, the clonal bone marrow plasma cells, BMPCs. How much percentage of bone marrow plasma cells are? Waldenstrom's macroglobulinemia is a completely different entity. I'll talk about that in a while. That doesn't come under multiple myeloma differential. Even though we tend to think as multiple myeloma, but the presentation, trust me, in clinical practice, the presentation of Waldenstrom's will be totally different. It won't come like multiple myeloma. Nevertheless, so BMPC, bone marrow plasma cells. Next is you have to see the M component, M protein component. And third one is going to be the myeloma defining event. That's called MD. I will tell in a short while what is MD or myeloma defining event. So in MGUS, the bone marrow plasma cells will be less than 10%. M protein will be less than 3 grams per deciliter. And the urinary M protein will be less than 0.5 grams per deciliter. Serum, it should be less than 3. Urine, it should be less than 0.5. And what about myeloma defining event? No myeloma defining event. None. There should not be any myeloma defining events. That is MGUS. What about smoldering multiple myeloma? Here, the patients will be having more than 10% okay, of bone marrow plasma cells, clonal bone marrow plasma cells. But please understand, it should be less than 60%. I'll repeat, it should be less than 60%. Why? Because more than 60% means it becomes a myeloma defining event. As per the definition, smoldering myeloma should not have myeloma defining event. Smoldering myeloma should not have myeloma defining event. It's an asymptomatic myeloma, so no myeloma defining event. So why I specifically told less than 60% is because if it's more than 60%, it becomes a myeloma defining event. That's why it should be less than 60%. But it should be more than 10. And M protein may be present or may not be present, which means it can be more than 3 or it can be less than 3 also. Okay, that's not the point here. It can be more than 3 or it can be less than 3 also. But the most important point here is the plasma cell number should be more than 10%. What about multiple myeloma? It will be more than 10%. Okay, number one, definitely. Patients may or may not have a M protein in the blood. Remember, many people think like myeloma means like there should be M spike. No, even without M spike, you can diagnose a myeloma, multiple myeloma. So plus or minus, which means it could be more than 5, more than 3 or less than 3. Usually it will be more than 3. Usually it will be more than 3 here also. But it can be less than 3 also. Some myeloma can be non-secretory myeloma. That's why it can be less than 3. And myeloma defining event, yes, this is a hallmark. This is the one that defines multiple myeloma. I'll repeat, the most important pointers towards multiple myeloma are bone marrow plasma cells more than 10% and the presence of myeloma defining event. So what about plasmacytoma? In plasmacytoma, you don't see plasma cells in the bone marrow, first of all. Okay, because that's a plasmacytoma, that's a soft tissue lesion. M protein may or may not be there, but usually it will be less than 3, more than 3 or less than 3. But generally here it will be less than 3. And there won't be any myeloma defining event also, which means it's purely a biopsy diagnosis. A soft tissue lesion, you biopsy to diagnose as plasmacytoma, that's it. So here the most important question is, what do you mean by myeloma defining event? MD, what do you mean by that? Because that is the one that's going to tell you that you're dealing with a multiple myeloma. What is myeloma defining event? So we used to use a mnemonic called as slim crab. So remember, this is not my mnemonic. This is the mnemonic that I'm very poor in forming mnemonics. This is given in the myeloma defining criteria itself. Myeloma working group committee is there. That's called MWG. They themselves are given this mnemonic. That's called as slim crab. MD stands for myeloma defining event. I told you. So slim crab. What do you mean by slim crab? S stands for 60%. Okay, 60% of bone marrow plasma clonal cells. Okay, bone marrow plasma clonal cells. Anything more than 60%. If the bone marrow plasma cells are more than 60%, it is a myeloma defining event. And next stands for light chains. Okay, LI stands for light chains. Okay, how will you define light chains? Light chains means SFLC, that's called serum free light chain ratio. SFLC ratio should be more than 100. Okay, SFLC ratio should be more than 100. SFLC ratio should be more than 100. I'll repeat, SFLC ratio should be more than 100. That's called serum free light chain ratio. Okay, apart from that, M. What does M stands for? MRI lesions. M stands for MRI lesions. Usually, we tend to do whole body MRI in certain patients, or alternative to MRI will be PET-CT. You can do PET-CT also. You should have at least 2 focal lesions. 2 focal lesions in MRI. Majority of the questions in exam will be targeting the criteria of multiple myeloma only. That's why this is very, very important. So 60%. Yes. Light chains means SFLC should be more than 100. And MRI or PET scan shows at least 2 focal lesions. 2 focal lesions. This is slim, myeloma defining event. What is CRAB? CRAB everyone knows. Okay, hypercalcemia, defined as calcium more than 11. Second is renal dysfunction, renal impairment, renal dysfunction. Okay, renal failure, renal dysfunction. Creatinine more than 2. A stands for anemia. Anemia means hemoglobin less than 10. Or at least 1 lytic bone marrow lesion. Lytic bone lesion. Lytic bone lesion. So this is CRAB, at least 1 lytic bone lesions. So this is CRAB. That's the mnemonic for slim crab. Okay, slim crab. So this is the myeloma defining event. If any one myeloma defining event is there, along with bone marrow plasma cell of more than 10%, that is multiple myeloma. Remember, the M protein usually will be positive. It will be more than 3, but even if it is less than 3, if the bone marrow plasma cell is more than 10%, and if there is a myeloma defining event, it is multiple myeloma unless proved otherwise. Okay. Dr. Swapna is asking, conduct sessions for NEET PG people also. See, I'm conducting sessions every week. We have already given a carousel in Instagram. In the Cerebellum Academy page, I've given, we have told that every week for NEET PG people, separately, they're going to be like system-wise discussion of most important questions. And along with that, this session is also going to be extremely useful for NEET PG also. Because I told you the board that's going to give the questions is the same. There's no change. Clear? So just read these topics, what I am discussing. Along with that, you go through those question and answer discussion that I'm going to discuss for the next 7 or 8 weeks. And I mean, what's more is required. I don't know. That much is enough for revision purpose, as far as I know. Okay, now you can understand. Okay, so now you can get it, isn't it? So what are you seeing? Okay, what are the differences? How to differentiate between MGUS, smoldering multiple myeloma, and plasmacytoma. Smoldering multiple myeloma is very simple. Smoldering multiple myeloma is nothing but multiple myeloma without MD. That's all. If you want to say in a simple language, if you want to say in a single word, smoldering multiple myeloma is nothing but multiple myeloma without a myeloma defining event. That's it. So that is equal to smoldering multiple myeloma. Fine. Got it. And how will you differentiate multiple myeloma from a Waldenstrom's macroglobulinemia? Waldenstrom's macroglobulinemia. Because many people are asking how to differentiate multiple myeloma from Waldenstrom's. There are some key features. Okay. So multiple myeloma patients will have, see how to differentiate. They'll have Crab criteria, Crab features, especially lytic bone lesions. Or I can simply say the lytic bone lesions are very, very important. Lytic lesions. That is never a feature of Waldenstrom's. Number one. Second important point is hepatosplenomegaly is very, very common in Waldenstrom's. It's extremely uncommon in patients with multiple myeloma. So no lytic lesions in Waldenstrom. Hepatosplenomegaly is very common in Waldenstrom's. And next, hyperviscosity features. Hyperviscosity. This is the most important feature in Waldenstrom. Multiple myeloma patients also can present. I'm telling, can also present, but it is uncommon. It is plus or minus. Not so common. Not very common. In selected patients only it will occur, but hyperviscosity is a very, very important feature of Waldenstrom. And multiple myeloma doesn't have any set mutations, but there is something called mid-88 mutations. Mid-88 mutations that are very, very common in Waldenstrom's, but it is not seen in patients with multiple myeloma. But more importantly, the type of cells itself will be different in Waldenstrom. In Waldenstrom, we are seeing LPLs. These are the malignant cells. Lymphoplasmacytoid lymphatic cells. Lymphoplasmacytoid lymphatic cells. Okay. But here you are going to see myeloma cells. Myeloma cells. Okay. Lymphoplasmacytoid lymphoid cells. Here you are going to see myeloma cells. Remember many people say CD138, CD38 and all. So LPLs will be CD20 positive. That's the most important. Myeloma cells will never be CD20 positive. It will be CD20 negative. It will never be CD20 positive. Okay. So, but CD38 and 138 is variable. So, myeloma cells generally will be CD38 and 138 positive. LPLs can be, some cells can be CD38 and 138 positive because it is lymphoplasmacytoid lymphoid cells. Lymphoplasmacytoid. So, they can have CD38, 138 positive in some cells. But the most important thing is majority of cells will be CD20 positive. That's the reason why rituximab is a very important part of therapy of Waldenstrom. But rituximab is not going to be effective in patients with multiple myeloma because they don't express CD20. That's all. That's a very important point. And what about other things? Okay, so Waldenstrom's can present with cold autoimmune hemolytic anemia. Cold autoimmune hemolytic anemia, number one. That's a very important point. So that's an associated feature because you know the antibody, most commonly it's going to be associated with IgM antibody, IgM. So multiple myeloma, most commonly it will be associated with IgG spike. Waldenstrom's is going to be most commonly associated with IgM. So that's why it can be associated with cold autoimmune hemolytic anemia as well. So that's why that's a very important point. So now you can see what are the differences. Easy, lytic lesions. Hepatosplenomegaly, hyperviscosity, IgM versus IgG, mid-88 mutations, LPL, CD20 or CD20, positive or negative. Rituximab, effective in Waldenstrom, not effective in multiple myeloma. Okay, cold autoimmune hemolytic anemia, common in multiple myeloma, Waldenstrom's because it's IgM. So these are the key pointers, okay? So Waldenstrom's, how to differentiate Waldenstrom's. And another important thing that they'll be asking in exam is the treatment of multiple myeloma. How will you treat? Currently, we use triple therapy, but evidences say that addition of daratumab is very, very important, but I don't know how much it's important for exam. So, but remember, triple therapy is what we use right now. So, what is triple therapy? We use dexamethasone, okay, dexamethasone, plus you're going to use an immunomodulator. That's called as IMiD. IMiD stands for immunomodulator. So there are plenty of immunomodulators. You can use either thalidomide, but we don't use it anymore because of high risk of peripheral neuropathy with thalidomide. Then we have something called as lenalidomide. Okay, lenalidomide. Then we have pomalidomide. Okay, so any one of these drugs can be used. Immunomodulators. Okay, pomalidomide. Then we are going to use a proteasome inhibitor. One proteasome inhibitor generally will be tried. So proteasome inhibitor can be either a bortezomib, but again bortezomib has a high risk of peripheral neuropathy, so don't use it in practice commonly. Currently we go for either carfilzomib or ixazomib. Carfilzomib, and we have something called ixazomib. So these are proteasome inhibitors. Remember, plus or minus, currently we are using anti-CD38 molecule. So this is also called as daratumumab. Daratumumab. There are plenty of other drugs, but at least bare minimum you need to know this. Daratumumab. So dexa, an immunomodulator, a proteasome inhibitor, and plus or minus anti-CD38 daratumumab. In high-risk patients, generally we add daratumumab. So that's what you need to know. Okay. So what are high-risk patients? Please study cytogenetics for that. But right now I don't have time to discuss the cytogenetics because it's not a very high-yielding information. Vincristine, vinblastine, it's outdated, man. We don't use all these drugs in patients with multiple myeloma as of now. So other neoplasms in hematology. Okay. So in that the non-Hodgkin lymphoma, okay, is going to be, Hodgkin and non-Hodgkin lymphoma. The other neoplasms means you're talking about lymphomas, right? The most important lymphomas. And talk about lymphomas, there are only two things, isn't it? Hodgkin lymphoma and non-Hodgkin lymphoma. So everyone knows the differences between Hodgkin and non-Hodgkin. But let me first tell the most important things about Hodgkin. Hodgkin, you have two types. So one is the classic Hodgkin lymphoma, and second one is nodular lymphocyte predominant Hodgkin lymphoma, NLPHL. Two types of Hodgkin is there. One is classic Hodgkin, second is nodular lymphocyte predominant. The most important is the classical Hodgkin because more than 95% cases will be classic Hodgkin only. Nodular lymphocyte predominant will be less than 5% on cases only, but it is the one that has the excellent prognosis compared to classic type. Non-Hodgkin type, non-classic type, the nodular lymphocyte predominant Hodgkin lymphoma only will have excellent to excellent prognosis. In fact, the best prognosis with nodular lymphocyte predominant Hodgkin lymphoma only. So classic Hodgkin lymphoma patients will have classic RS cells. We all know that. Whereas nodular lymphocyte predominant Hodgkin lymphoma patients will have non-classic cells. What are non-classic cells? These are also called as popcorn type of Reed-Steinberg cells. Popcorn type of Reed-Steinberg cells. So classic Hodgkin lymphoma patients will be typically CD15 positive and CD30 positive, 15 positive, 30 positive, but CD20 negative. It's the opposite in these patients. These patients will be CD15 negative, 30 negative, but they can have 20 positive. Okay. So see, there are subtypes of classic Hodgkin lymphoma. Zolensma is telling that mixed cellularity. See, there are many subtypes, and pathology teachers would have taught you obviously. Like you have nodular sclerosis type, mixed cellularity type, lymphocyte rich type, lymphocyte poor type. In that they were taught like mixed cellularity is the one that's usually associated with Epstein-Barr virus commonly. Lymphocyte poor type is associated with HIV virus. Lymphocyte rich among the classic types that has the good prognosis. Nodular sclerosing type will have that collagen bands, and it is one of the very common forms. All these things they would have already taught you in pathology, so there is no point in discussing. I'm going to talk only about the most important points that are going to be asked in exams. Remember, see, there are plenty of molecules that are available in hematology, but the problem is, like, look at the papers, the PYQs, those are important. If you look at the PYQs, the questions from hematology are fairly simple, straightforward, uncomplicated. Okay, so they're not going to ask too much with regards to hematology questions. Okay, so what is the treatment? Treatment is going to be ABVD regime. That's all. ABVD regime. That's what you need to know. Plus or minus involved-site radiotherapy. So if you know this much, it's going to be more than enough. A stands for adriamycin. That is nothing but doxorubicin, bleomycin, vincristine, dacarbazine. I'll repeat: adriamycin, bleomycin, vincristine, dacarbazine. Okay, so this is ABVD regime. Plus or minus you can use in selected patients ISRT, that is involved site radiotherapy. So this is the treatment for Hodgkin lymphoma. And So if they ask you where rituximab will be helpful in nodular lymphocyte predominant, because it's CD20 positive, you can use something called as rituximab. And if they ask you a newer drug that is going to be effective for classic Hodgkin lymphoma type, that is called as brentuximab vedotin. That's called brentuximab vedotin. Brentuximab, BRENTUXIMAB vedotin. This is a special monoclonal antibody. I will not talk about that right now. But anyway, so it's an anti-CD30 molecule that's going to be effective for classic Hodgkin lymphoma. So rituximab for nodular lymphocyte predominant, classic Hodgkin, brentuximab vedotin. So these are the important things about Hodgkin. So many times you will get this picture, which is a classic Reed-Steinberg cell. Can you see that? And you can see this is the popcorn type of Reed-Steinberg cell that's seen in nodular lymphocyte predominant Hodgkin lymphoma. This is a classic Hodgkin lymphoma. Then when you talk about non-Hodgkin lymphoma, this is a big topic, non-Hodgkin lymphoma. So let me discuss in a little bit of detail when it comes to non-Hodgkin lymphoma. So you have some aggressive tumors. Okay. So what are the aggressive tumors when it comes to non-Hodgkin lymphoma? So you have Burkitt's lymphoma, and number 2 you have DLBCL. These are the aggressive form of tumors, Burkitt's and DLBCL. So Burkitt's, first how will you suspect? Cells will be medium sized, but more importantly the classic pattern in exam, the starry sky appearance. Everyone knows that. So just let us recap. Starry sky pattern. So we are going to see those stars in the sky, which are nothing but tingible body macrophages. You'll have a sheet of tumor cells with tingible macrophages which are going to appear as starry sky. And second point, very high proliferation index. Ki67 will be more than 97%. Very, very high proliferation. So it's a very aggressive tumor. In fact, the most aggressive tumor is Burkitt's lymphoma. Ki67 will be more than 67%. And definitely CD10 will be positive because it's a follicular origin lymphoma. CD10 will be positive. And another important point is T814 translocation. So which is going to involve the c-MYC. So remember, it could be T28 translocation or T822, whatever it is. That 8 is a very important number because that Burkitt's lymphoma patients will have a c-MYC translocation. Okay, c-MYC amplification will be there. That's typical of Burkitt's lymphoma. It could be T28 or T822, but T814 is the most common and that's the most important. So what is the treatment of Burkitt's lymphoma? Aggressive tumors treated aggressively. You have to give something called R-Codox, then followed by MR-IVAC regimen. So the expansion is little difficult, but R-Codox, MR-IVAC is the standard treatment of choice. So it's a highly aggressive tumor and it's a treatable tumor. Aggressive tumors may be aggressive and kill you, but it's curable. That's the speciality of aggressive tumors. So Burkitt's lymphoma. Starry sky, Ki67 more than 95%, CD10 positivity, T814 c-MYC amplification. Okay, R-Codox, MR-IVAC is going to be the treatment of choice. Okay, all right. And presentation wise, how they're going to present? They're going to present as a jaw mass. That's called endemic Burkitt's, or they can present as a GI mass in the ileocecal region, like your GI mass. That's also possible. So either jaw mass, okay, in case if it's a endemic Burkitt's in Africa, or GI mass if it's a non-endemic Burkitt's. So any of the presentations. What about DLBCL? So Burkitt's medium cells, DLBCL large cells, diffuse large B cell lymphoma. Okay, large cells, no starry sky, large cells, no starry sky. That's why starry sky is very important. No starry sky here. And another important point is Ki67 will be less than 95%. Even though this is an aggressive tumor, it's not hyper aggressive like Burkitt's, not hyper proliferative. Here the Ki67 will be less than 95%. And more importantly, CD10 and BCL6 both will be positive many times in many tumors. This will be the clue. CD10 and BCL6 both will be positive. And it can occur anywhere. DLBCL can occur in the lymph node, DLBCL can occur in the GIT, it could be anywhere. It's a tumor that can occur anywhere, even in the brain in HIV patients, called primary CNS lymphoma. Number 3, in between, not aggressive, not so like non-aggressive. That is mantle cell lymphoma. So that stands in between. It's not aggressive, not a non-aggressive tumor, somewhere in between, mantle cell lymphoma. You're going to see medium cells only, but the most important pointer is CD5 positive, CD23 negative. So this is what they will ask you in exam. CD5 positive, CD23 negative. And more importantly, they're going to have T1114 translocations. Okay, T1114 translocations, which is going to increase the activity of cyclin D1. Cyclin D1. cyclin D1 overamplification. So this is the point that you need to know. That's all, nothing more than that. 11-14 translocation, cyclin D1 hyperamplification. Okay, overamplification. SOX11 will be positive, that everyone can tell. But see, that and all is not very commonly asked in exam. It's the cyclin D1 overamplification and T11-14 mutation. That translocation, that's going to be more important. And how will you treat mantle cell lymphoma and DLBCL? These are the tumors that typically respond to R-CHOP regime. R-CHOP. These are the tumors that typically respond to R-CHOP. Both DLBCL as well as mantle cell lymphoma. Okay. Fourth, marginal zone lymphoma. Marginal zone lymphoma. Okay. So marginal zone lymphoma is of three types. One is called as nodal marginal zone lymphoma. Nodal. Second is ENMZL, that is extranodal marginal zone lymphoma. And apart from that, you have something called splenic marginal zone lymphoma. Three types are there. In that, what they will ask in exam? They will ask the extranodal marginal zone lymphoma. So why? Because this is related to H. pylori. This is related to H. pylori, extranodal marginal zone lymphoma. And it's going to most commonly involve stomach, and it's going to cause something called as gastric malt lymphoma. Gastric malt lymphoma. And what is the translocation that you need to know in marginal zone lymphomas? The T11-18. That's what they will ask you in exam. The T11-18 translocation. Because this is MALT1 gene related. There is an overamplification of a gene called as MALT1. That is the reason for development of this lymphoma. And I'll tell you one more interesting thing here. The H. pylori related maltomas will not have the translocation, the characteristic T11-18 translocation. And another interesting point is that H. pylori related gastric maltoma, the treatment is H. pylori eradication. H. pylori eradication is the treatment for most of the gastric maltoma related to H. pylori. That's a very important point. You don't need to even start with chemotherapy. That's why they tend to ask that question. And what is the importance of splenic marginal zone lymphomas? Splenic marginal zone lymphomas will have hairy cells. Hairy cells. So it can create a confusion with hairy cell leukemia. But the difference is here you will have a polar villi. Polar villi. Not a hair throughout the cell. Only the polar portion of the cell you will have the villi. So you can see hairy cells in splenic marginal zone lymphoma. So that's why that point is important. So it creates a confusion in the peripheral smear with that of hairy cell leukemia. And what about other tumors? So we have something called follicular lymphoma. These are indolent tumors. Now we are coming to non-aggressive, indolent, very indolent, non-aggressive tumors. Follicular, what are the important points? The patient is going to present with lymphadenopathy. And more importantly, CD10 will be positive. That's a follicular marker. The germinal center marker is CD10. And BCL2 will be positive. That's the most important point here. BCL2, because they tend to commonly have a translocation called as T14-18 translocation that amplifies BCL2. BCL2 over amplification. That's the key. Okay, BCL2 over amplification. So they're going to present painless lymphadenopathy. That's the usual presentation. Okay, treatment is R-CHOP. Aggressive tumors is R-CHOP, but non-aggressive tumors you can treat in a better way. Even many patients will not be even treated. You can just observe them. That's enough. What about hairy cell leukemia? HCL, hairy cell leukemia. So important points, BRAF positive, BRAF V600E mutation positive, BRAF V600E mutation positive, hairy cell leukemia. And then you're going to have CD103 positivity, CD103. Obviously, annexin A1 will be positive, but CD103 and 123 positive, and 103 is more important. And you'll see hairy cells in the peripheral smear. TRAP positive, number 4. Patients are going to be elderly, predominantly male patients, elderly males, massive splenomegaly. Massive splenomegaly. But most of the times, they don't have lymphadenopathy. Most of the times, they don't have lymphadenopathy. Key features, okay? And they tend to have cytopenias. They present with cytopenias, some anemia, thrombocytopenia like that. Cytopenias. So elderly, cytopenias, massive splenomegaly, no lymphadenopathy, BRAF V600E positive, CD103 positive, TRAP positive, tartrate resistant acid phosphatase. That is HCL. Plenty of times asked in exams. Treatment of choice, cladribine. Okay, treatment of choice, cladribine. Cladribine. Number 7, CLL, SLL. Okay, chronic lymphocytic leukemia or small lymphocytic lymphoma. So what are the keys in exam? Smudge cells. Okay, smudge cells. That's a key in exam. Smudge cells, smudge cells, smudge cells. Peripheral smear. CD5 positive, CD23 positive. Okay, both. And they won't have overamplification of cyclin D1 to differentiate it from mantle cell lymphoma. So remember CD200 also will be positive but not specific. That's not important. But CD5 positive, 23 positive. Asked in most exams. Treatment of choice, ibrutinib. It's a Bruton tyrosine kinase inhibitor. Ibrutinib, first line treatment for CLL right now. Ibrutinib. So whenever it's NHL, don't always say R-CHOP. Okay, it depends. Hairy cell leukemia, cladribine. Your CLL, SLL, ibrutinib. Your Burkitt's lymphoma, you're going to treat with R-Codax, MR-IVAC. And for follicular lymphoma, you don't need to even treat most patients. Okay, so don't always say R-CHOP. So if you want to say R-CHOP, it should be either DLBCL or at least a mantle cell lymphoma. So for other things, don't answer R-CHOP. So that's it. So it's done, right? So what are the important things? So here is a patient with hairy cell leukemia. You can see the image over here. And this is the trap positivity of patients with hairy cell leukemia. That's what the image is showing. And here is a patient with splenic marginal zone lymphoma. Splenic marginal zone lymphoma, where here also you will see hairy cells, but you will see typically a polar villi. Okay, polar villi. You don't see a hairy projections throughout the cell. And here is an example of a cleaved lymphocyte, so which is also called as buttock cells, which is seen in some patients with aggressive forms of follicular lymphoma, where the malignant cells will leak into the peripheral smear, and that you can see as buttock cells or cleaved cells, cells with cleaved nuclei. And these are the examples of smudge cells, okay, in the peripheral smear, suggesting that this is a CLL, and patients will have a lot of lymphocytes in the peripheral smear as well. And whenever you see this kind of cells with folded nucleus like a brain gyre, these are called as cerebriform cells. And here you can suspect something called as Sézary syndrome. These are also called as Sézary cells. Okay, cerebriform nucleus, Sézary cells. Okay, it's a feature of mycosis fungoides and Sézary syndrome. And I think everyone would have studied a lot about mycosis fungoides and Sézary syndrome in your pathology itself. So I'm not going to discuss any further. So these are the high-yielding information with regarding to the neoplasms in hematology is concerned. So let us move on to deficiency anemias. So what are the important things about deficiency anemia? So they will ask something about the iron deficiency anemia first, then we'll move on to B12 deficiency. So in iron deficiency, you're going to see something called as koilonychia, which are nothing but spoon-shaped nails. And what are the features of iron deficiency anemia? The most common cause is blood loss, okay? So don't say nutritional deficiency. Nutritional deficiency is very rare, even in developing countries. And blood loss is the most common reason. You're not replacing sufficient amount of iron compared to that of how much amount of iron that you're losing from the body. So blood loss is the most common reason, most common cause. And what are the indices of iron deficiency? Number one, the first indices is the low bone marrow iron stores. Decreased bone marrow iron stores. This is often the first thing that you notice, but we don't do bone marrow biopsy for all patients. That's the reason why this is not very important. Next comes the low ferritin. Okay, next will be the low ferritin level. This is the first detectable change in clinical practice. Bone marrow we don't do for all patients. That's why this is of vital importance, low ferritin. And slowly your TIBC starts increasing. Okay, total iron binding capacity will increase. Then your transferrin saturation will start dropping. So what is transferrin saturation? It is iron by TIBC. In a patient with iron deficiency anemia, transferrin saturation will be less than 18%. This is a very important number. Iron by TIBC will be less than 18. That is, transferrin saturation will be less than 18%. And patients tend to have low serum iron as well. Low serum iron as well. Finally, and they will have increased red cell distribution width. And lastly, at the end only, patients will have low hemoglobin. Okay, that's the last stage. Anemia is the last. Okay, red cell distribution width also will increase. I think people are telling TIBC, all other parameters will decrease. No, even RDW will be high, more than 13-14%. Okay, red cell distribution width also will increase. So these are the classic features of iron deficiency anemia. Why is important? Because you need to differentiate from something called as anemia of chronic disease or anemia of chronic inflammation, where the patients will have increased ferritin. Okay, because ferritin is an inflammatory marker. Ferritin is a positive acute phase reactant. You know, albumin is a negative acute phase reactant. Likewise, ferritin is a positive acute phase reactant. And these patients will have normal to high ferritin. And other things will be same. And they will have low TIBC, but that's not important. They will have low transferrin saturation. But remember, even though they have low transferrin saturation, the transferrin saturation will be more than 18%. This is a very, very important point. Okay. In fact, how to differentiate between a concomitant iron deficiency in a patient with anemia of chronic disease. For example, I'm having a rheumatoid arthritis, right? And I can have iron deficiency also. How will you differentiate? By TSAT only. My ferritin is not reliable. In a patient, if I'm having iron deficiency and having a chronic inflammation, ferritin is not reliable there. Ferritin can be normal or high in that situation. So what will tell you that it's associated iron deficiency is TSAT. The TSAT is more than 18. Think about only anemia of chronic disease. If the ferritin is high and if the TSAT is less than 18%, that confirms it's iron deficiency. That's why in mixed situations and all, TSAT will be very, very helpful. And serum iron will be low here as well. And red cell distribution width will be increased here as well. There won't be much difference. It's not that important over here. And again, low hemoglobin will be there. So the most important pointers are going to be the ferritin. It will be high here. Okay, the TABC, that will be low here. TSAT, even though reduced, the value will be more than 18%. So these are going to be the important differences between iron deficiency anemia and anemia of chronic disease. And next, coming to the B12 deficiency. B12 and folate deficiency. So how will you differentiate between B12 and folate deficiency? So both are going to cause megaloblastic anemia. Both are going to have megaloblastic anemia. TABC will be reduced. So TABC will be definitely reduced in patients with anemia of chronic inflammation, chronic disease. Okay, so let us go to the megaloblastic anemia. So how will you differentiate between B12 and folate deficiency? So B12 deficiency patients will have anemia, and folate deficiency patients also can have anemia. Okay, and megaloblastosis will be seen in bone marrow in both. There's no doubt. But what is more important is neurological changes. Neurological changes will be there only in B12 deficiency. It is not a feature of folate deficiency. What are the neurological features? Patients can develop peripheral neuropathy. Patients can develop dementia, because in fact it's a very important cause of reversible dementia. And patients can have SACD, that is subacute combined degeneration of the spinal cord. So remember, subacute combined degeneration of the spinal cord is basically due to demyelination, whereas peripheral neuropathy is axonal. That's a very important point. Okay, B12 deficiency can produce axonal neuropathy and it can produce spinal cord demyelination also, both together. So peripheral neuropathy is not demyelinating, it's axonal as far as B12 deficiency is concerned. So and next is methyl and your homocysteine levels. Homocysteine levels will be increased in both. But what is going to differentiate is your serum methylmalonic acid levels. It will be increased only in B12 deficiency, whereas serum methylmalonic acid will be normal in patients with folate deficiency. Remember, both serum folate levels and serum B12 levels are unreliable for diagnosis. So if you want to diagnose folate deficiency, use RBC folate. Even that's an exam question. RBC folate is better. Don't use serum folate. Okay, RBC folate is better. For B12 deficiency also, serum B12 is unreliable. It only tells you the recent dietary pattern. So use homocysteine and methylmalonic acid for diagnosing B12 deficiency. And look at this patient. This is the classic knuckle hyperpigmentation that is seen in many patients with B12 deficiency. It's not been described in folate deficiency, so it could be one of the important differences between B12 and folate deficiency. So this is seen typically in B12 deficiency, the knuckle hyperpigmentation. In deficiency anemias, you know the treatment of choice is going to be replacement with oral iron or IV iron in selected patients, and you can give either oral B12 or IM B12 depending on what is the situation. Remember, in Western countries, the most important reason for B12 deficiency is pernicious anemia. So you need to know a little bit about pernicious anemia as well. There are two antibodies, anti-intrinsic factor antibody and anti-patelle cell antibody, which is going to result in atrophic gastritis. So you cannot produce intrinsic factor. So patients will end up with B12 deficiency. Okay, if it's a pernicious anemia, IM B12 is better because oral absorption will be very poor. And second important cause is vegans. And probably when you are good in microbiology, you'll also tell that fish tapeworm, Diphyllobothrium latum, also can produce B12 deficiency. But honestly speaking, that vegans and pernicious anemia are the two most important causes as far as your Indian subcontinent is concerned. So vegans, those who don't eat any animal products, including dairy products like milk, curd and all. So they are the ones who are more prone for deficiency. Folate deficiency occurs in patients who don't take sufficient greens. So in greens only you have good amount of folate. If you don't take greens, you end up with folate deficiency. So patients who don't take sufficient amount of greens tend to get folate deficiency in particular. So then coming to thalassemia. So there are two types of thalassemia, as everyone knows. We have alpha thalassemia and we have beta thalassemia. So what is the difference? Alpha thalassemia is usually due to deletions. Beta thalassemia is usually due to mutations. Usually due to point mutations or frame shift mutations. Okay, beta thalassemia. So beta thalassemia is basically not due to deletions. Beta thalassemia is due to mutations. Deletions means deletions of the alpha gene. That is alpha thalassemia. Alpha thalassemia can present at birth or even in utero, but beta thalassemia will never present at birth or in utero. It will present only after 6 months, because after 6 months only a beta gene becomes important. There will be a transition from fetal hemoglobin to adult hemoglobin. So beta thalassemia will never present at birth, but alpha, depending on severity, can present at birth or even in utero. So single alpha gene deletion. So they will be carriers. Carriers in the sense they will be completely asymptomatic, and even the peripheral smear will be normal. Everything will be normal. Even electrophoresis will be normal. Electrophoresis will be normal. Hemoglobin electrophoresis will be normal. Everything will be normal. Only way to detect these patients is genetic testing. That's all. Or you can have two beta gene deletions. Two alpha gene deletions. Two alpha gene deletions will present like a thal minor. That's called alpha thal minor. So what do you mean by thal minor? Patients will be asymptomatic, but the peripheral smear will show microcytic hypochromic RBCs. Maybe slight anemia could be there, but you can see microcytic RBCs here. But another important point is electrophoresis will still be normal in patients with alpha thalassemia with 2 gene deletion. What about 3 gene deletions? This is called 3 gene deletion. 3 gene deletion will present at birth or in utero. Most of the times the presentation will be similar to thal intermedia, which means they can present at birth, or severe cases can present in utero also. Severe cases can present in utero also. So these patients will be symptomatic. Okay, these patients will be symptomatic and they'll have microcytic hypochromic anemia, severe anemia in fact. So the hemoglobin will be only approximately around 7, not more than that. Okay, hemoglobin will be 7 or 8 generally, very low hemoglobin, and they will be symptomatic. And they will have splenomegaly, they will have features of ineffective erythropoiesis, and they will have growth failure because of severe anemia. So they will be symptomatic for sure, but most importantly, most of them will not be transfusion dependent. Most of them will not be transfusion dependent. So then only you can call it as intermediate. So major means they will be transfusion dependent. So if it's, what is the electrophoresis finding? Electrophoresis, you will see something called as hemoglobin H. In the peripheral smear, they will be appearing as golf ball cells or golf ball inclusions in new methylene blue staining. But electrophoresis, you will see specifically HBH, which are nothing but beta-4 tetramers. Beta-4 tetramers. Without alpha genes, all the beta will unite together and club together. That's HBH. No alpha gene at all. They are going to present as thal major only, which means they will be typically transfusion dependent. And because alpha chains are important in the embryonic life itself, they are going to present in utero, death in utero. So what do you mean by transfusion dependency? Unless and until you transfuse these children in the womb itself. So this mother should receive intra natal transfusions, which means the fetal transfusion should occur. If you don't do fetal transfusions, these kids are going to die inside the uterus itself because of severe hydrops and heart failure. Severe hydrops fetalis, death in utero. And they are transfusion dependent, because thal major means transfusion dependent only. If you don't do intrauterine transfusions, they will die. And electrophoresis will typically show something called as hemoglobin BARTs. So what is hemoglobin BARTs? These are gamma-4 tetramers. These are gamma-4 tetramers. This is hemoglobin BARTs, gamma-4 tetramers. What about beta thalassemia? Beta thalassemia is due to mutations. Could be point or friendship mutations. And based on the phenotypes, we can describe as beta 0 and beta plus. If somebody is having beta 0, they will be usually presenting as thal major. They will be usually presenting as thal major. Thal major means they will be symptomatic and they are transfusion dependent as well. They will be transfusion dependent also, symptomatic and transfusion dependent. if they are having at least one beta, okay, one beta gene to be normal, at least one if it is normal, beta 0 beta or beta plus beta. Okay, beta plus means something is produced but not completely normal. So beta plus beta or beta 0 beta, these patients will present as thal minor. So what do you mean by this? If at least one beta gene is normal, at least one is normal, then they will present as thal minor only. So these patients will be asymptomatic, but definitely will have microcytic hypochromic RBCs, but they will be completely asymptomatic. And more importantly, electrophoresis will show a very important point. Electrophoresis will show hemoglobin A2 levels of more than 3.5%. Hemoglobin A2 levels of more than 3.5%. So if at least one beta is normal, thal minor presentation, electrophoresis abnormal. HbA2 will be more than 3.5%. That's the key feature. Remember, the most important difference is alpha thal minor will be having normal electrophoresis, whereas beta thal minor patients will have abnormal electrophoresis. That's a very important point. If it is beta 0, beta plus, or maybe beta plus, something like that, they are going to present as thal intermedia, or depending on the severity, they can present as thal major also. So both are affected, but at least one component is beta plus. Okay, if that is the case, then they can present either thal intermedia commonly or sometimes thal major, depending on how much beta chains these patients are producing. So if they present with thal intermedia, that's a clinical diagnosis. Patient will be symptomatic, but they will not be transfusion dependent. They will have variety of problems, like they will have anemia, they will have growth failure, they will have splenomegaly, they will have so many problems, but they will not be transfusion dependent, which means transfusion is not required to maintain survival. That's the idea. So that is thal intermedia, symptomatic but not transfusion dependent. Okay, so these are the major differences between alpha and beta thalassemia. Whenever the moment you diagnose thal major, means they need regular transfusions. Without regular transfusions, they will die. You have to maintain them with transfusions only. So do you understand whatever I'm talking about? So alpha versus beta thalassemia. And to diagnose thalassemia and to screen for thalassemia in India and in low resource countries, they use a test called NESTROF test. That's called naked eye single tube red cell osmotic fragility test. It's very, very simple. You're going to test the patient's blood in a buffered saline. So 1 or 2 drops of blood in a buffered saline. If the line is visible or if the RBCs are lysed, this is a negative test. If the line is not visible, the line is invisible. Can you see the line is invisible in buffered saline, which means it's a positive test. You can suspect thalassemia. So what all you need to know is line visible, line invisible. That's all. Line visible, line invisible. Visible line, no thalassemia. Invisible line, thalassemia. That's all. So because thalassemia is a very important topic for your exams. Next, coming to 2 other important topics, PNH, paroxysmal nocturnal hemoglobinuria, and hereditary spherocytosis. These are another 2 important topics. PNH, you know what is the problem? So PNH, the problem is the PIG-A gene. That's the problem. PIG-A gene. Okay, that's going to produce GPI anchors. PIG-A gene that's going to produce GPI anchors. So what are the 2 most important GPI anchors? CD55 and CD59. So because of loss of GPI anchors, PIG-A gene defect, there will be loss of GPI anchors. They will have complement mediated damage. There will be overactivation of complement, and that will result in damage to the cells, complement-mediated damage. That's the problem. So they activate the complement, complement proteins are there, but the CD59, 55 and 59 are the ones that protect the cells from complement-mediated damage. So if those are not there, then complement will start attacking the blood cells and it's going to result in problems. So what is the typical feature? Triad of PNH. PNH patients are going to present with hemoglobinuria. Typically this will be nocturnal in nature. That's why it's called paroxysmal nocturnal hemoglobinuria. That's because of intravascular hemolysis. And then patients are going to have pancytopenia. And third, they're going to have thrombosis. Cellularity of the marrow will depend, but more often than not, these patients will have a cellular marrow. A classic PNH will have a hypercellular marrow only. So there are associations with aplastic anemia. I'm not denying that. There is an association with aplastic anemia. But in exam, whenever they say PNH, think about a cellular marrow. There is an association with aplastic anemia where you can have a hypocellular or acellular marrow. But exams, Classic PNH, cellular marrow. Hemoglobinuria, pancytopenia, thrombosis. That's it. And thrombosis is the most common cause of death. Second most common cause of death is infection. The most common cause of death is thrombosis. Okay. So when you suspect PNH, whenever the thrombosis occurs in unusual areas. Unusual areas. What are the unusual areas? Cerebral venous thrombosis. That's called cortical venous thrombosis. Budd-Chiari syndrome, mesenteric vein thrombosis, portal vein thrombosis. Which means if there is thrombosis in the abdomen, splanchnic circulation, or in the cortical veins, think about PNH as one of the possibilities. Thrombosis. Okay. So what is the treatment? Investigation of choice is going to be flow cytometry. Okay, that's the investigation of choice. You need to look for the CD55 and 59 component in the blood cells. And treatment of choice, if they ask you, eculizumab. That's an anti-C5 monoclonal antibody that reduces the damage to the cells. So eculizumab. So that's the treatment of choice. And what about hereditary spherocytosis? What are the important pointers? So number one, patients will have strong family history because autosomal dominant disease, most commonly due to ankyrin mutations. Most commonly due to ankyrin mutations. Spectrin mutations usually will produce hereditary elliptocytosis. Here most commonly it's going to be due to ankyrin mutations, autosomal dominant disease. And patients will present with anemia. Because of anemia, patient will have growth failure. They can have gallstones because of hemolysis. And usually this will be pigment gallstones. Made of bilirubin pigment. And third, chronic non-healing leg ulcers. Okay, so these are the three classic manifestations of hereditary spherocytosis. If you do peripheral smear, because it's a hemolytic anemia, patients will have normal MCV, which means it's not a microcytic hyperchromic anemia. Basically, it's a normocytic normochromic anemia. And an important feature, if at all you ask me, what they will ask you is the MCV will be normal. Okay, MCV will be normal. And MCHC alone will be increased. That's because spherocytes are compact cells. Part of the membrane is removed. So it will become more compact. So MCHC alone will increase. I'll drink water, but I don't have water in front of me. So let me finish it off. I think another half an hour session is left and I'll finish it off and I'll move on. So MCHC will be increased. That's a very important point. MC will be normal though in patients with hereditary spherocytosis. And more importantly, you're going to see the classic spherocytes in the peripheral smear. And more importantly, if you see spherocytes, the important differential diagnosis is autoimmune hemolytic anemia. So you need to prove that DCT is negative in this case. Which means the direct Coombs test or direct antiglobin test will be negative. In autoimmune hemolytic anemia also you can see spherocytes, but there DCT will be positive. But if they ask you investigation of choice, it is EMA right now. EMA testing, flow cytometry, where you're going to do a testing called as EMA testing. That's called eosin-5 maleimide testing. Osmotic fragility testing is outdated. Even though OFT will be positive, currently we don't do OFT for diagnosis of hereditary spherocytosis. We do EMA testing, that is eosin-5 maleimide testing. Treatment of choice is splenectomy. There is no other option. So we don't want to remove spleen. We tend to treat conservatively. But if the patient is transfusion dependent, the most important indication is transfusion dependency. If you need recurrent transfusions and the child is transfusion dependent, for survival, splenectomy is the best treatment option. So investigation of choice is EMA testing, eosin-5 maleimide testing, and treatment of choice is splenectomy. So this is hereditary spherocytosis. Hematology, I think, is done. Now, let me tell you another important point, because many times whenever I talk about hematology, I need to discuss some oncology at least. So tumor markers are extremely important. So let us discuss one important Harrison table. So where important different tumor markers are given. So what about, yes, Dr. Aslam Alam definitely will pass. Don't worry about that. Always keep that spirit. So first I can split into hormonal markers, enzyme markers, tumor associated protein markers. What are the hormonal markers? Number one is HCG, human chorionic gonadotropin. And where you're going to see in hydatidiform mole. So currently we don't use the term hydatidiform mole. We don't use the term. Rather we use a term called gestational trophoblastic disease. That's the right now. And germ cell tumors, especially gonadal germ cell tumors. Gonadal germ cell tumors. These are two tumors that's going to show positive beta HCG or elevated beta HCG, but a non-neoplastic condition that's going to show elevated beta HCG is pregnancy. Everyone knows that. That's a physiological condition. Calciton. So the most important is MTC, medullary thyroid cancer, and catecholamines, pheochromocytoma. Pheochromocytoma. But in pheochromocytoma, if they ask you the investigation of choice, answer is metanephrin, urinary metanephrin. VMA testing is outdated now. We don't do vanillin mandelic acid testing in the urine. It is metanephrin. And what about oncofetal and I think this should come here, oncofetal antigens. So where you see elevated AFP in hepatocellular cancer and in germ cell tumors. Germ cell tumor means we are talking about gonadal germ cell tumors. Gonadal germ cell tumors, hepatocellular cancer and germ cell tumors. So what are the other situations where alpha fetoprotein can be increased? Cirrhosis. Cirrhosis and hepatitis. Cirrhosis and hepatitis. So these are the non-neoplastic conditions where alpha fetoprotein can be elevated. So another antigen is your carcinoimmunogenic antigen, that is CEA, where it will be elevated in adenocarcinomas. So typically you tend to think about colon, but not only colon, it's a non-specific marker. It can be increased in colon cancer, it can be increased in pancreatic cancer, it can be increased in breast cancer, ovarian adenocarcinomas, lung adenocarcinomas, everywhere. But in exam, remember colon, okay? But any adenocarcinoma for that matters can have a elevated CEA. So non-neoplastic condition, yes, plenty of condition, but the most important is pancreatitis. Pancreatitis and even hepatitis can have elevated CEA. So it's a non-specific marker. And even IBD, inflammatory bowel disease, even smokers tend to have elevated CEA. That is the reason why, to be honest, in CEA report, I don't know how many of you have seen the CEA, carcinoimmunogenic antigen report. In the CEA report, they would have given smokers and non-smokers. If the individual is smoking, they would have given a separate cutoff value for them because CA will be elevated in smokers. This could be a attracting point for examiners as well. So, but cancer-wise, it's adenocarcinoma. Prostatic acid phosphatase, yes, it's prostate cancer. Prostate cancer. There are plenty of other conditions where this can be elevated, like BPH and prostatitis. In these situations also, it can be elevated. Neuron-specific enolase. So here you're going to think about small cell lung cancer or neuroblastoma. In case any cancers of neuroendocrine origin can have a elevated neuron-specific enolase. LDH typically in lymphomas, especially non-Hodgkin lymphomas, and in Ewing sarcoma. Ewing sarcoma. So any lymphoma, especially non-Hodgkin lymphoma and Ewing sarcoma. Okay. What about tumor-associated proteins, prostate-specific antigen? We know prostate cancer. That's where it's going to be elevated. And where it's not elevated is, where it's non-neoplastic condition where it is elevated is prostatitis and BPH, which we know already. And monoclonal immunoglobulin is for myeloma and other, plasma cell discresis also, but myeloma is very important. But non-neoplastic condition where monoclonal antibodies can be increased is infections, connective tissue disorders, and MGUS. Infections, connective tissue disorders, and MGUS. Many infections can cause elevated gamma globulins in the system. Many connective tissue disorders, including rheumatoid arthritis, SLE, Sjogren and all, can increase the immunoglobulin levels in the body, and MGUS, as we all know, is going to increase. CA125. So where you see typically in ovarian cancer. This is what is more important for exams. Ovarian cancer and sometimes breast cancer. It's given in Harrison, but in exam answer, ovarian cancer as first. And what about non-neoplastic conditions? Menstruation. That's a very important non-neoplastic condition. During menstrual cycle, CA125 can be increased. And in pregnancy also, CA125 can be increased. And in patients with peritonitis, CA125 can be increased. Okay. So, but ovarian cancer is more important. CD30. So, where CA19-9, where CA19-9 in patients with colon cancer, pancreatic cancer, and in patients with breast cancer. But most important is the pancreatic cancer. Most important. Like CEA for colon cancer, CA19 exam, first thing you have to answer is pancreatic cancer. Non-neoplastic condition, pancreatitis. Non-neoplastic condition, pancreatitis and ulcerative colitis. In exam, make a watch on ulcerative colitis as well. CD30. CD30 Hodgkin lymphoma, especially classic type. Classic Hodgkin lymphoma, CD30 positive. And another one is anaplastic large cell lymphoma. Even this is an important point. Anaplastic large cell lymphoma, ALCL. And CD25, hairy cell leukemia, CD25. And another disease called as ATLL, adult T cell lymphoma leukemia, which is associated with a virus called as HTLV1. That's associated with also virus called as HTLV1, adult T cell lymphoma leukemia. But these are the two conditions where CD25 will be elevated. So what is the condition where non-neoplastic condition where CD25 will be elevated? HLH. Trust me, this is also a very, very important point. In fact, one of the criteria for diagnosis of hemophagocytic lymphohistiocytic syndrome is elevated soluble CD25 in the blood. HLH. HLH will have a elevated CD25. So this table is so important, because when it comes to NEET PG FMGE examiners, they tend to ask in and out about this table. That is why I gave separately 5 minutes for this table. Okay, so don't forget this. Now going to important infections. Only 3 infections are important. So first, one is CAP, second is meningitis, and third one is going to be the infective endocarditis. And that community acquired pneumonia, I think we have discussed already in the in your respirology session previously. So when you talk about community acquired pneumonia, the CURB 65 score is the one that's going to be most important. So everyone knows CURB 65 score: confusion, urea more than, blood urine nitrogen more than 20, then respiratory rate more than 30, then BP, SBP less than 90 or DBP less than 60, and age more than 65. Each carries 1 point. So if the score is 0 or 1, you're going to manage as OPD. If the score is 2, you're going to manage as short inpatient. And if its score is 3 and above, you're going to manage as a full IP plus or minus patient need a ICU care. Okay, so that's what they're going to ask in exam. So CURB 65, you need to know the parameters of CURB 65, and you're going to decide on whether to admit the patient or to treat the patient as an OPD basis. And each and every step, what are the antibiotics to give also is very important, which is something that we've discussed in the respirology sessions itself previously. And what about this one? So here is the typical pneumonia picture: consolidation, air bronchogram. So this is what you get in exam, air bronchogram. So urea not more than 7. So in Western standards, they would have given blood urine nitrogen more than 7. So they are confused about urea, right? Blood urine nitrogen more than 7, but this is millimoles per liter, right? That's millimoles per liter. So, but in India, we have to know milligrams per deciliter. That is blood urine nitrogen more than 20 milligrams per deciliter. In India, you are going to use this term only. That is milligrams per deciliter only. That is the reason why this is important. I hope you understand. This is the Western standard, UK standard. Blood urine burn more than 7 millimoles. Burn more than 20 is Indian standard, 20 milligrams per deciliter. So you can see the air bronchogram here. So that is a consolidation. It's a very typical feature of CAP. So let us move on to the next one. Meningitis. In meningitis, the most important table is this one. So opening pressure can be increased in all types of meningitis: bacterial, fungal, TB, viral, everywhere. But the cell types are very important. If it's bacterial, you're going to have increased neutrophils. If it's viral, TB, or if it is fungal, your lymphocyte count will be high. Protein will also be increased in all, but very mild increase in protein will be seen in viral, but massive increase will be seen in tuberculosis. The most important point is the glucose as well. Glucose will be reduced in bacterial, fungal, as well as TB, but it will be normal in viral. That's a very important point, because virus cannot utilize glucose. They don't have the metabolic machinery to utilize glucose. Okay, that's all. All right. So this is the important table that you need to know. So most of the questions will be based on this table only, which everyone knows. So some important images with regards to meningitis. So you can see that this is the cobweb coagulum. I think this is asked in the recent exam. So that is seen in tuberculosis patients or tuberculous meningitis because of very high level protein. And here is the example of basal exudates. So whenever they give basal exudates in the CT or MRI, that is equivalent to tuberculosis. And this is the India ink preparation that shows cryptococcal meningitis. That shows cryptococcal polysaccharide. It doesn't stain the capsule. So the India ink is a negative stain, doesn't stain the capsule. Okay, so that's why it's called as a negative stain. You see the typical soap bubble appearance that is suggestive of cryptococcal meningitis. So 3 points: cobweb coagulum TB, basal exudates TB, soap bubble appearance in India ink or probably in whatever staining you do, that is cryptococcal meningitis. Remember, but the important test, the test of choice in cryptococcal meningitis is not India ink, it is CRAG. You have to do serum and CSF CRAG. CRAG should be done in the serum or in the CSF, the cryptococcal antigen test. That is the currently preferred test for diagnosing cryptococcal infection. Serum or CSF CRAG, that is cryptococcal antigen. India ink is very, very poor in detecting as well as confirming cryptococcal meningitis. So its sensitivity is hardly 20 to 25%. So we don't use India ink preparation as a reliable test. The reliable test is CRAG, serum or CSF cryptococcal antigen. Okay. Now coming to infected endocarditis, you know what are these diagrams and what is the important part in infected endocarditis. We have discussed already enough in our previous sessions. So this is the rod spot. The most important point that they tend to ask in rod spots is that the rod spots are hemorrhagic spots. Okay, so and the rod spots are example of immunological phenomenon. And you're going to have splinter hemorrhages. It's not given in any criteria as such, but very commonly seen in patients with infective endocarditis. And these are the Janeway lesions. These are the Janeway lesions, which are basically painless lesions that occur in the palms and soles. Palms and soles. And Janeway lesions are basically vascular phenomenon. They are not immunological phenomenon. They are basically vascular phenomenon. And finally, you have the osteolar nodes. Osteolar nodes occur in the fingers and toes. There is a difference between palms and soles and fingers and toes. Osteolar nodes occur in fingers and toes, and they are basically painful lesions, and they are immunological phenomenon. So rod spots and osteolar nodes are immunological phenomenon. Janeway lesions are vascular phenomenon. Splinter hemorrhages are not a part of criteria itself. Osteolar nodes you can differentiate based on the pain, okay, and Janeway lesions will be more maculopapular, and osteolar nodes will be more nodular, and fingers and toes typically for osteolar nodes, and palms and soles typically in Janeway lesions. So there are plenty of differences between them. And what are the important areas? I think in my PYQ session itself I covered this. So remember, the prophylaxis is the most important area. The prophylaxis is the most important area. So in important PYQs and important table discussion, like one of the sessions before, I have discussed on the prophylaxis of infective endocarditis. So what are the important indications? There are 5 important indications. I told you already. Number 1, prior infective endocarditis. Number 2, cardiac transplant with valvulopathy. Number 3, patients with prosthetic valves. Number 4, unrepaired cyanotic congenital heart disease. Number 5, repaired congenital heart disease. Either there should be leak, ongoing defective repair that's causing a leak, or if there is a prosthetic material, for the first 6 months you give prophylaxis. Only 5 indications. I'll repeat: prior infective endocarditis. Second, cardiac transplant with valvulopathy. Number 3 is going to be presence of prosthetic valves. Number 4, unrepaired cyanotic congenital heart disease. Number 5, repaired congenital heart disease. Either there is a defective repair, there is an ongoing leak, or patient should have a prosthetic material. In that situation, first 6 months you give prophylaxis. Okay, for what you give prophylaxis? Only for 2 procedures. One, for bronchoscopic biopsy. Number 1, for respiratory procedures that are invasive, bronchoscopic biopsy. Dental procedures. Only for 2 procedures you give prophylaxis. What drugs you prefer? You're going to prefer amoxicillin or ampicillin. Okay, and this has to be given as a single dose 30 to 60 minutes prior to the procedure. 30 to 60 minutes prior to the procedure. Just a single dose. Alternative in patients with penicillin allergy is clindamycin. Clindamycin is an alternative to patients with penicillin allergy. So amoxicillin or ampicillin, single dose 30 to 60 minutes prior. Alternative is clindamycin. Only for 2 procedures: dental and bronchoscopic biopsy. Dental, bronchoscopic biopsy. Dental, bronchoscopic biopsy. Only 2 procedures. Indications, I told you, 5 indications. For what procedures? I told you. What is the drug? I told you. When to give? I told you. Alternative in patients with penicillin allergy, clindamycin. Okay, that's it. Infected endocarditis is done. So another one is HBV serology. So this is another common question that they tend to ask in exam. So let me give you an algorithmic understanding. So many times you would have seen a table everywhere, but this time I thought I'll give an algorithmic approach for understanding how HBV serology works in exam. So first look at the HBsAg. HBsAg. Okay, first is HBsAg. HBsAg can be negative or HBsAg can be positive. If HBsAg is negative, okay, then look at anti-HCV. Anti-HBs, importantly, anti-HBs. If anti-HBs is positive and HbS-Ag is negative, means it's a vaccinated status. Okay, vaccinated status. If anti-HbS is negative, okay, then look at anti-HCV. Anti-HCV. Anti-HbS alone is positive, look at anti-HCV. If anti, maybe I think I can. One second, it's not working properly. Just hold on. Just 1 second. I'll come back. Okay, sorry. Welcome back. So I think there was a lot of lag here. So that is why I just refresh the session. Sorry for a little bit of time. So let me come back. So how to approach an SBA serology. So first look at HbS-Ag. So if it's negative, you have to look at anti-HBC. So if anti-HBC is positive or anti-HBC is negative, that's what indicates. If anti-HBC is positive means patient is exposed to the virus. If anti-HBC is negative means patient is unlikely to be exposed to virus because anti-HBC is a marker of exposure. I'll repeat, anti-HBC is a marker of exposure. Whereas HbS-Ag is a marker of infection. HbS-Ag is a marker of infection. Anti-HBC is a marker of exposure. HbS-Ag is a marker of infection. Anti-HBC is positive means patient is exposed to the virus. The next step is look at anti-HbS. We know anti-HbS is a marker of immunity. Anti-HbS is a marker of immunity. If anti-HbS is positive or negative, that's what we need to know. So anti-HBC positive. Anti-HBC is positive and anti-HbS is also positive. Means patient is exposed to the virus in the past. It indicates a past exposure. Patient has recovered from the infection, but the patient is having a past exposure. Okay? Or we can call it as recovery. Patient has recovered from a past infection. That's why HbS-Ag is now negative, but anti-HbS is positive and anti-HBC is also positive. So if anti-HBC is negative, then again look at anti-HbS. If anti-HbS is positive, but anti-HBC is negative, HbS-Ag is also negative means it indicates vaccination. Isolated anti-HbS positivity. It indicates vaccinated status. If anti-HbS is also negative, which means patient is not exposed and not vaccinated. Patient is not exposed, not vaccinated. That's what it means. Anti-HbS negative and anti-HBC is also negative means very likely patient is not exposed to the virus and not vaccinated also. That's why anti-HBS is negative. If anti-HBS is negative, okay, anti-HBS is negative, but anti-HBC alone is positive, isolated anti-HBC positivity, which means patient is exposed to the virus in the past, but we don't know. Exposed, but whether they have developed immunity or not, we don't know because anti-HBS is negative, which means it could be a very remote exposure. It could be a remote exposure. Remote means the patient could have exposed to the virus for like 20-30 years ago. So that's why the marker of exposure is positive, but because they have had a very remote exposure, the marker of immunity becomes negative. Okay, that's the idea here. So now we can understand. So if HbA1c is positive, so what you will do? It's a marker of infection. HbA1c positive means patient is having definitely infection. Okay, and another important reason for anti-HbA1c positive alone is you can think about window period. Correct. Some people are answering correctly. Window period. Another evidence here is window period. But how will you differentiate between a very remote exposure and a window period? In remote exposures, anti-HbA1c IgG will be positive. IgG will be positive. Whereas during the window period, your anti-HbA1c IgM will be positive. Anti-HbA1c IgM will be positive. In a very remote exposure, anti-HbA1c IgG will be positive. In the window period, anti-HbA1c IgM fraction will be positive. That's how you determine. So whenever there is an isolated anti-HbA1c positivity, these are the two possibilities. So when HbA1c is positive means patient is having infection. Okay, so that's the most important point. So now next step is look at anti-HbA1c again. Anti-HbA1c again. Anti-HbA1c can be positive or anti-HbA1c can be negative. Anti-HbA1c can be positive or anti-HbA1c can be negative. If HbA1c is positive and anti-HbA1c is negative, it's very likely to be a false positive HbA1c. Likely it is a false positive HbA1c. So you have to redo the test. It's unlikely that HbA1c is positive, you have to redo the test. Or sometimes in very recently vaccinated individuals, this can happen because what you use in vaccine, use hepatitis B surface antigen. That's what you're injecting in the patient. So that circulating surface antigen can produce a false positive surface antigen positivity. So it's very likely to be a false positive result. So redo the test. It's very unlikely. If HbA1c positive and anti-HbA1c is positive, then next step is to look at anti-HbS. Okay. If anti-HbS is positive, I mean, it's extremely unlikely anti-HbS will be positive in this case. If anti-HbS, it won't be positive. So it can be negative only because here surface antigen is positive, right? So anti-HbS will be negative only. Okay. So usually in this case, anti-HbC positive, HbA1c positive, and positive, you see the fraction. If it's IgM fraction, that, sorry, here I think I'm messing up a little bit. The reason is like I'm getting little dizzy because of almost like 3.5 hours we are crossing, I think. My voice is getting dizzy. So look at whether IgM or IgG fraction, which is positive. If IgM fraction is positive, then you're going to think about an acute infection. If IgG fraction is positive, then going to think about a chronic infection. So what they'll be asking you is, in case if it's a chronic infection, whether it's EAG positive or E antigen negative. EAG positive or E antigen negative. EAG positive means this patient is having a highly infectious disease, high infectivity, because E antigen is a marker of infectivity. So high rate of infection, high rate of infectivity. So if E antigen is negative, then low rate of infectivity. That's what it means. So again, if normal ALT means you're going to call it as inactive disease. If the patient is having increased ALT, you're going to call it as active hepatitis or active disease. That's it. Same thing applies here also. If it's a normal ALT, you're going to call it as inactive disease. If it's increased ALT, you're going to call it as active disease. That's all. So this is the exact algorithmic approach to your hepatitis B serology. This will give a great clarity. Okay, so how to approach a patient with HbA1c positivity or negativity. So let me repeat: HbA1c negative, look at anti-HbC. Anti-HbC positive, look at anti-HbS. If anti-HbS is also positive, it's a past exposure record. If anti-HbS is negative, patient is exposed, which could be a remote infection or it could be in the window period. Anti-HbC IgG positive means it's remote. Anti-HbC IgM positive means it's a window period. And if HbA1c negative, anti-HbC negative means then next step is look at anti-HbS. If anti-HbS is positive, it indicates a vaccinated status. Isolated anti-HbS positive means it's always vaccination. If anti-HbS is negative, patient is not exposed, not vaccinated. That's what it means. If HbA1c is positive, usually anti-HbS will be negative only in this situation. So what you're going to see is anti-HbC. If anti-HbC is positive, A negative, then it means false positive HbA/Ag. If anti-HbC is positive, see IgM or Ig fraction. If IgM fraction is positive, then it's acute infection. If IgG fraction is positive, it's a chronic infection. If it's a chronic infection, the E antigen becomes very important to confirm the infectivity. So E antigen positive, high infectivity, E antigen negative, low infectivity. Then whatever may be the case, look at the ALT. If ALT is normal, it's inactive hepatitis. If ALT is increased, it's a active hepatitis. That's it. So this is how we are going to categorize the entire HBV serology. So every time you would have studied the table form. Now for a change, I have tried to give in the algorithmic analysis, which is also going to be very, very useful for your exams. Okay, so let us move on to the next. So after knowing the HBV serology. So we have only like 4 more slides. We are coming to the end of the marathon. So first is UGI bleed. So how will you diagnose and treat an UGI bleed? So remember, when I talk about UGI bleed, 2 are extremely important. The most common cause is peptic ulcer disease. That is the most common. Second most common cause is varicose bleed. So varicose bleed. So if it's going to be varicose bleed, what will be the clues in exam? If it's going to be varicose bleed, in your exams, the clue will be patients, they would have a straightforward case of cirrhosis, or they can say that the patient is having ascites and jaundice. Some stigmata of liver disease will be there, like ascites and jaundice. That tells you that the patient is having a varicose bleed. So what is this one? This is an example of a Mallory-Weiss tear that they can ask commonly in exam, usually common in alcoholics. So when you are retching or when you are vomiting, sometimes because of increased intragastric pressure and intra-abdominal pressure, it can cause tear in the cardiac portion of the stomach. The most common location of tear is the cardia, near the esophagogastric junction. So alcoholism, UGI bleed. Think about Mallory-Weiss. Alcoholic, UGI bleed. Think about Mallory-Weiss as the possibility. And they will have a little bit of chest pain also during retching. That's because of the tear. Yes, that's a very important. It's a partial tear, correct. It's not a complete tear. It's a partial tear. Complete tear will become Buraf syndrome. Remember, complete tear will not present with UGI bleed. They'll come with chest pain because of pneumomediastinum. And here is an endoscopic picture of varices. These are basically esophageal varices, right? So you can see these are like dilated venous columns in the lower end of the esophagus. These are esophageal varices. The question is how you're going to treat this patient. So for example, patient is presenting with a varicose bleed. How you're going to treat? Number 1, first is ABC. You have to give fluids and maintain the blood pressure if the patient is hypotensive. Second, you can consider blood products. So what are the indications for blood products? I'll tell you the universal indications. Indication number 1 for PRBCs. For PRBC, indication is hemoglobin less than 7. Second, platelets. When we give platelets, if the platelet count is less than 50,000. Platelets if the platelet count is less than 50,000. Third, FFPs. When we give FFPs, if the INR is more than 2. If INR is more than 2, then only give FFPs. Third is cryoprecipitate. When we give cryoprecipitate, if the fibrinogen levels are less than 100. If the fibrinogen levels are less than 100, you're going to give cryoprecipitate. So these are the 4 important indications for blood products in any disease. I'm telling in the form of varicose bleed, that's all. Third, you need to give some vasoactive agents. So what are the vasoactive agents? So one is terlipressin, second is octreotide. Any one you can give, not both together. But terlipressin is preferred because it reduces mortality. If you don't have terlipressin, you can give octreotide also. Number 4 is broad spectrum antibiotics like piperacillin, tazobactam or meropenem, because infections are very common in a varicose bleed. So broad spectrum antibiotics. That's a very important point. Number 5, endoscopy should be done within 12 hours, preferably within 12 hours, to find out what is the site of bleed. So it could be esophageal varices or it could be gastric varices. Esophageal varices or gastric varices, any one. If it's a esophageal varices, the first line treatment option is EVL, that is called endoscopic variceal ligation, which is simply referred in practice as banding. That's called endoscopic variceal ligation, simply called as banding. If it's a gastric varices, you cannot band those gastric varices. What you have to do is, you need to do something called cyanacrylate injection, cyanacrylate glue injection. Cyanacrylate glue injection, that's what you need to do. Or alternatively, you can do radiographic coiling, coil embolization. You can find out which is the vessel that is the culprit by angiography, and you can coil embolize them. So this is all right. But in our hospital, we commonly use cyanoacrylate glue injection. But EVL will not be effective for gastric varices. Remember, the most common is esophageal varices only. Gastric are rare, but it's little dangerous. Suppose if the patient is presenting with refractory or recurrent bleed. If they ask you refractory or recurrent bleed, what will you do? You're going to do TIPS. TIPS is the next step. They say refractory or recurrent bleed, TIPS. Refractory or recurrent bleed, TIPS. That's all. That's called transjugular intrahepatic portosystemic shunt. So when will you use the balloon tamponade? So these are the devices that are helpful for balloon tamponade, right? Balloon tamponade. When will you use balloon tamponade? Balloon tamponade is preferred only in emergency control. If you want an emergency control of a dying patient, you can use balloon tamponade. Otherwise, don't use. So if you are able to do endoscopy, and if you are able to visualize the bleed, and if you are able to do banding and all, there is no role for balloon tamponade. In patients who are unstable and patients who are dying, hypotensive, or in endoscopy room, you are not able to see anything, full of blood. So if you want to achieve an emergency bleeding control, balloon tamponade is okay. Remember, within 24 hours, you have to remove the balloon tamponade and go to definitive management. It should be applied only for less than 24 hours. More than 24 hours, high risk of esophageal necrosis and perforation. Only in emergency cases. Okay, so what are the three important devices? SBT, Sengstegen-Blakemore tube. Linton-Nachlas, Minnesota tube. Most commonly used is SBT, Sengstegen-Blakemore tube, where are going to have two balloons, gastric balloon and esophageal balloon. Along with that, there will be 3 ports. Okay, 3 ports. So 3 ports, 2 balloons, Sengstegen-Blakemore tube. How will you identify Minnesota tube? You will have 5 ports, 2 balloons, both gastric and esophageal balloon, but you will have 5 ports. That is Minnesota tube. Linton-Nachlas is specifically designed for controlling gastric varices only. So it has only gastric balloon. That itself tells you it's Linton-Nachlas. Once again, it's going to have 3 ports only. So 3 ports, 2 balloons, SBT. 3 ports, 5 ports, 3 ports, 2 balloons, SBT. 5 ports, 2 balloons, Minnesota. Only gastric balloon, 3 ports, Linton-Nachlas. Linton-Nachlas can control only gastric varices. Okay. So that's the important point with regards to UJ bleed. And cirrhosis and portal hypertension. I'll tell you the important pointers only. So this is something I've discussed in the PYQ and important table session itself. So most importantly, they will ask you about this ascitic fluid analysis in cirrhosis and portal hypertension. So what will you do? So first thing, you have to see the SAG ratio. So what is SAG ratio? SAG ratio is nothing but serum albumin minus ascitic fluid albumin. You have to calculate both and you have to subtract. So the SAG ratio is more than 1.1. It is equal to portal hypertension. That's all. It's equal to portal hypertension. The SAG ratio is less than 1.1. It is not portal hypertension. The SAG ratio is less than 1.1. It is not portal hypertension. So once the SAG ratio is more than 1.1, it is 99% specific for portal hypertension. So in that situation, you have to see ascitic fluid total protein, either less than 2.5 or more than 2.5. The ascitic fluid total protein is less than 2.5, which means it's called as low protein high SAG ascites. It is due to sinusoidal cause. The most common sinusoidal cause is cirrhosis. That's all. Apart from that, acute liver failures, acute hepatitis can produce this. Some malignancies like HCC or metastasis can produce, but the single most important cause is cirrhosis. High SAG, low protein, cirrhosis, that's it. High SAG, high protein, the protein is high. Then it's not sinusoidal. It could be either pre-sinusoidal or post-sinusoidal cause. The two most important pre-sinusoidal causes are EHPO, that is extrahepatic portal vein obstruction, which typically tends to occur in children after umbilical vein catheterization. Most cases will have history of umbilical vein cannulation. Children. And NCPF is non-cirrhotic portal fibrosis. Cystosomiasis is a theoretical cause, but we very rarely see. So cystosomia mansoni or japonicum, okay, that's a very rare cause. Okay, we don't see that commonly, cystosomiasis. But EHPO and NCPF are practical causes. NCPF tend to occur in young adults. So usually NCPF and EHPO patients will not have liver failure. They will only present with splenomegaly and probably variceal bleed. Even ascites won't be there that much. Okay, variceal bleed and splenomegaly are usual features of EHPO and NCPF, and they don't have signs of liver failure, and very minimal ascites only will be there. So EHPO, NCPF, most important pre-sinusoidal causes, along with cystosomiasis. Post-sinusoidal causes, cardiac causes, that's called cardiac cirrhosis, right heart failure causing congestive hepatomegaly, Budd-Chiari syndrome. Remember, acute Budd-Chiari syndrome will be having post-sinusoidal type picture only, but if it's a chronic Budd-Chiari, Late Budd-Chiari syndrome will present with cirrhosis only. That's why they will mimic a picture of high SAG, low protein ascites. But acute Budd-Chiari will have a picture of high SAG, high protein ascites. Then there is something called sinusoidal obstruction syndrome. What is sinusoidal obstruction syndrome? Typically, this tends to occur after bone marrow transplant, post BMT. Okay, post BMT, you are going to get sinusoidal obstruction syndrome. So in exam, anyone who's presenting with hepatomegaly ascites after a bone marrow transplantation, think about sinusoidal obstruction syndrome or SOS. If they ask you treatment, there is a special drug called as defibrotide that is used as a treatment for SOS or to prevent SOS, sinusoidal obstruction syndrome. So this is a very important table. And whenever SAG ratio is less than 1.1, think about exudative ascites like peritoneal carcinomatosis. Okay, most of the patients will be elderly or patients will be frail or they will have severe weight loss. Elderly, frail patients with severe weight loss. Okay, think about peritoneal carcinomatosis. Biliary leak peritonitis. Honestly speaking, I had a case yesterday, biliary leak peritonitis. Usually there will be a history of biliary surgery, especially laparoscopic cholecystectomy. Just yesterday, don't believe, just yesterday we diagnosed a case of biliary leak peritonitis, where 5th post-operative day, one lady, 36-year-old lady, underwent a cholecystectomy, laparoscopic cholecystectomy, presented with fever and abdominal pain. When you examine the abdomen, the patient had abdominal distension. And when we examined the case and when we took an ascitic fluid analysis, the SAG ratio was less than 1.1. After cholecystectomy, SAG less than 1.1. What else is going to be there? Biliary leak peritonitis. We sent the fluid for bile salt, bile pigment. It was positive. And the patient is having repeated enlargement of the abdomen even after tapping the ascitic fluid. So we sent the patient for MRCP that confirmed there is a CBD leak because of CBD injury. And currently, tomorrow we are posting the patient for stenting. Okay, that can control the bile leak to some extent because it's a very small leak. So maybe it will settle down, or if the patient is not settling down with the stenting also, we are going to do a repeat surgery. So we can do biliary diversion or something like that, depends on the surgeon. Okay, so this is biliary leak peritonitis. That's very common. And nephrotic syndrome. You know how nephrotic syndrome is going to present with. They're going to have proteinuria, edema, other features will be there. Pancreatitis, you know, elevated amylase lipase, abdominal pain will be there. Tuberculosis, you know, patients are going to have B symptoms like weight loss and other constitutional features like low-grade fever. Okay. So that is going to be tuberculosis. So whenever SAG ratio is less than 1.1, it is not portal hypertension. SAG ratio more than 1.1, it is portal hypertension. Some of the important treatment alone I will tell you. So how to treat SBP and how to diagnose SBP. Spontaneous bacterial peritonitis, when will you suspect? When the ascitic fluid neutrophil count is more than 250. So when the ascitic fluid neutrophil count is more than 250, you can think about spontaneous bacterial peritonitis. Treatment is broad spectrum antibodies. In Western textbooks, they would have given ceftriaxone as the first line treatment. But in ICMR guidelines, in Indian guidelines, they have mentioned piperacillin tazobactam. Because of high level resistance to ceftriaxone in most centers, ICMR guidelines recover, suggest piperacillin tazobactam, but ceftriaxone is what is mentioned in Harrison and Western textbooks. Bowel perforation or infection, yes, that also is a possibility. Somebody has pointed out correctly. That's called secondary bacterial peritonitis. I'll repeat, that's called secondary bacterial peritonitis. Secondary bacterial peritonitis. So now there comes a difference. Secondary bacterial peritonitis also will present with SAG ratio of less than 1.1. So secondary bacterial peritonitis means there is an infection primary that is causing ascites. That is causing ascites. That is called as secondary bacterial peritonitis. So what is spontaneous bacterial peritonitis? Spontaneous bacterial peritonitis means there is an ascites that is pre-existing. On top of that, the patient is getting infection. So which means the ascites is getting infected. That is SBP. Spontaneous bacterial peritonitis. Secondary bacterial peritonitis means infection causing ascites. Example is perforation of the bowel, which causes fecal peritonitis. Okay, so that's an example of secondary bacterial peritonitis. But SBP is different. Okay, it tend to occur in cirrhosis patients or nephrotic syndrome patients. And ascites, that is getting infected. Ceftriaxone or cefotaxime, that's what is mentioned in the Harrison. But ICMR guidelines recommend piperacillin tazobactam. And next is hepatorenal syndrome. Another important thing that you need to know, hepatorenal syndrome will be treated with, urgent treatment will be with terlipressin and albumin. Okay, you have to give albumin infusions along with terlipressin. That's the treatment. Alternative to albumin will be octreotide, but octreotide alone will not be enough. You might need to use noradrenaline also. Octreotide, not noradrenaline, octreotide can be used. That's an alternative. Or another alternative will be noradrenaline plus midodrine. This is poor man's choice, noradrenaline with midodrine. So the standard treatment is terlipressin with albumin for hepatorenal syndrome. Alternative to terlipressin is octreotide along with albumin. And alternative to octreotide is also noradrenaline and midodrine. So this is what we are going to try. Okay, so these are the important points that you need to know for like your liver disease, especially cirrhosis and portal hypertension. So what about autoimmune liver disease? There are three important autoimmune liver disease. One is autoimmune hepatitis. Second one is going to be primary biliary cirrhosis. And third one is going to be primary sclerosing cholangitis. So what are the important pointers? In autoimmune hepatitis, patient will be usually a female. Generally, patient will be a female, and usually they will be middle-aged female. And they're going to present with elevated ALT and AST. Elevated ALT and AST. Bilirubin may or may not be elevated, but ALT and AST elevation is very important. And antibody-wise, ANA will be positive. And other antibodies also can be positive, like anti-smooth muscle antibody. That's called SMA. Smooth muscle antibody may be positive. Anti-LKM1 can be positive. Liver kidney microsomal antibody can be positive. Or anti-SLA, soluble liver antigen, may be positive. What about PBC? What about PBC? PBC will have elevated ALP and GGT because it's a primary biliary cholangitis, biliary problem. ALP will be elevated and total bilirubin may or may not be elevated. Here, AMA will be positive. That is mitochondrial antibody will be positive. In PSC, again you will have increased ALP only, alkaline phosphatase, but usually antibody will be negative, but rarely P-ANCA can be positive. P-ANCA can be positive, but this is rare. Only 30% case will have P-ANCA positivity, and this is also atypical. And this is not a specific antibody. That is why it's not mentioned in many textbooks. It's not very specific antibody. For that matter, P-ANCA can be positive in autoimmune hepatitis also. So that's why it's not specific. And what are the other key pointers? Clinically, what will be the key pointers? When it comes to autoimmune hepatitis, elevated IgG will be a key pointer. Okay, patients can have other associated autoimmune disorders, and elevated IgG is a key pointer. And in PBC, elevated IgM can be there, and along with that, patients can have xanthomas. That's a very important clue. Xanthomas, and patients can have Zika symptoms. Zika means dryness of the eyes, mouth, skin, and all. Zika. These are very classic symptoms of primary biliary cirrhosis. And whenever you have a primary sclerosing cholangitis, there will be history of IBD, especially ulcerative colitis. So history of IBD will be there. Okay, ulcerative colitis. That's a key. What about ERCP? If you do ERCP, this will be normal. Okay, ERCP will be normal here. Actually, it's not required. First of all, why ERCP is not required? Because this is a hepatocellular problem. You know, ALT, AST is elevated. Why you want to do ERCP and MRCP? So it's not required basically. ERCP, or alternatively you can do MRCP also, magnetic resonance cholangiopancreatography. So in MRCP, in PBC it will be normal, whereas it will be abnormal. You are going to see strictures and dilatations. Strictures and dilations. And what will be the treatment? Treatment wise, corticosteroids plus or minus azathioprine. Immunosuppression is the treatment here. In primary biliary cirrhosis, UDCA is the first line treatment, ursodeoxycholic acid. In PSC, UDCA doesn't work, so it's only palliative. You have to treat the underlying cause. Treatment of IBD, along with that, stenting can be tried. Biliary stenting can be tried, but ultimately all these disorders can result in liver failure. So if they end up with chronic liver failure and cirrhosis, you have to look at options like orthotopic liver transplantation only. So treatment of IBD plus or minus stenting, that's the treatment here. So you can see that this patient is having primary biliary cirrhosis because I have demonstrated the xanthomas, okay, extensive xanthomas. And here is a patient with PSC, primary sclerosing cholangitis, where you can see strictures and dilatations. You can see strictures and dilatations in the extrahepatic biliary tree. So what will be the biopsy picture? Biopsy in autoimmune hepatitis will be showing interface hepatitis. Okay, interface hepatitis. Biopsy in PBC will be showing ductopenia, bile ductopenia with granulomas. Whatever bile ducts that are remaining, that will be attacked by granulomatous inflammation, ductopenia and granulomas. What do you see in PSC, peribile duct onion skin fibrosis. Small bile ducts will have onion skin fibrosis. Onion skin fibrosis. That's what you see in PSC, primary sclerosing cholangitis. So this is all about your autoimmune liver disease. That's it. It's done. So final slide. So what about the LFTs? I think this is something I've discussed, but still let me tell you one more time because it's a very important pointer. LFTs also that you need to know for exams. So what about hepatocellular pattern? When the patient is having hepatocellular pattern, the ALT levels will be high. The AST levels also will be high, increased. Alkaline phosphatase may be normal or increased. If it's an hepatocellular pattern, depends. Bilirubin can be normal or increased. Again, it depends, but ALT, AST elevation is the most important. What about viral hepatitis? If it's a viral hepatitis, the ALT elevation will be more compared to that of the AST elevation. I told you already in the previous classes itself, ALT elevation will be more than AST elevation. So where typically the AST-ALT ratio will be less than 1. I'll repeat, AST-ALT ratio will be less than 1 in patients with viral hepatitis and NASH. What about alkaline phosphatase? Can be normal or can be increased. Bilirubin can be normal or it can be increased, depends. What about alcoholic hepatitis? In alcoholic hepatitis, your AST elevation will be more than ALT elevation. Your AST elevation will be more than ALT elevation. That is why in alcoholic hepatitis, your AST-ALT ratio will be generally more than 2. That's called as de-Ritis ratio. AST-ALT ratio will be more than or equal to 2. And typically in acute viral hepatitis, the ALT will be in the thousands generally. The AST-ALT will be in the thousands. In chronic viral hepatitis, your ALT can be normal or ALT can be slightly increased, like it will be in the 50s and 100s. 50s and 100s in chronic viral hepatitis. In acute viral hepatitis, usually it will be in the thousands. In NASH also, it will be mildly elevated only, like 50, 60, 70, something like that. That's all, nothing more than that. In alcoholic hepatitis, even though AST levels are elevated, it will be less than 400 only. I don't know how to write here. I can write here. In alcoholic hepatitis, AST will be less than 400. That's a very important point. There won't be significant increase in AST. That is because of pyridoxine deficiency that is going to be present in most alcoholics. Pyridoxine is an important cofactor for both AST and ALT. So that's when alcoholics, even though AST levels are high compared to ALT, you don't have an AST of more than 400. Often it will be less than 400 only. And similarly, alkaline phosphatase can be normal or increased, and bilirubin can also be normal or increased. That's characteristic. What about ischemic hepatitis? In ischemic hepatitis, AST and ALT will be elevated tremendously. In fact, maximal AST-ALT elevation you will get in ischemic hepatitis only. Especially if you are thinking about a severe shock patient or patients who are presenting after a cardiac arrest. So those patients can have very high AST-ALT, like 10,000, 15,000 and all. Okay. So alkaline phosphatase levels alkaline phosphatase also usually will be increased, and bilirubin also will be usually increased in most patients at presentation. But very important clue is history of ischemia, history of shock or cardiac arrest. That's a clue in these patients, and most of the patients will have a very quick resolution. Very quick resolution. Extremely quick resolution. Once you resolve the ischemia, the OTPT will settle. The AST-ALT will settle down. What about Wilson disease? We are talking about acute Wilson, fulminant presentation of Wilson disease. ALT levels will be increased. AST levels also can be increased. Alkaline phosphatase levels will be decreased. Okay, in acute fulminant Wilson, that's a very important point. Usually, you don't study causes that reduce the alkaline phosphatase levels. Wilson is one of the classic conditions, especially in acute fulminant Wilson. Alkaline phosphatase can be reduced. Bilirubin can be increased. One important ratio that you need to know for acute Wilson is alkaline phosphatase by total bilirubin ratio, which will be less than 4. That tells you that bilirubin elevation will be more, but alkaline phosphatase levels will be reduced, so that the ratio will be less than 4. That acute fulminant Wilson. You know the treatment of Wilson, isn't it? Primary treatment is chelation. Chelation means you're going to give trientine or depenicillamine. Trientine is preferred because of low side effects, even though it's costly. For maintenance treatment, you can give zinc. So what about cholestatic picture? Cholestatic picture, AST-ALT can be normal or increased, ALT can be normal or increased, but ALP will definitely be increased along with GGT levels, and bilirubin levels will be generally increased, and most of them will be direct component. conjugated bilirubin. Mostly will be direct. Even in all this hepatic injury also, it will be direct component only. Even all these conditions, predominantly it will be a direct component. In Wilson alone, because of hemolysis, unconjugated bilirubin can be increased, indirect fraction can be increased, but in most hepatocellular cause also, predominantly it will be a direct fraction. In cholestatic, needless to say, it will be a direct fraction only. Infiltrative conditions usually will have a near normal AST and ALT. Only ALP will be increased. Like sarcoidosis, tuberculosis, or even metastatic conditions. When you talk about infiltrative, you have to think about hepatocellular cancer and metastasis also. Liver mets also. In fact, one of the important clues for liver metastasis is isolated ALP elevation. That's a very important point. Isolated ALP elevation. Bilirubin can be normal or increased. It depends. It's a very late stage. These are all normal or increased. And infiltrative conditions also, the first presentation is increased alkaline phosphatase. They also present in a similar fashion only. But I can say that what I can say is near normal. Infiltrative conditions will have near normal AST and ALT. Only ALP will be elevated along with GGT. What about non-hepatic causes like skeletal muscle injury? So ALT will be normal. I think it's ALT. No, it's AST, right? So ALT will be normal. AST alone will be increased. Okay, that too only mild increase will be there, and everything else will be normal. Okay, there's nothing else. If it is skeletal muscle injury, if it's a bone disease, only alkaline phosphatase will be increased. But remember, here GGT will be normal. That tells you it's a bone problem for sure. But in cholestatic and infiltrative condition, GGT also will be increased, suggesting it's really a cholestatic problem. But in a bone problem, only alkaline phosphatase will be increased because this is a bone-related alkaline phosphatase, not a liver-related alkaline phosphatase. Bilirubin will be normal as well. The classic example is hyperparathyroidism and Paget's disease. Classic example. There are many examples, but the classic example will be hyperparathyroidism and Paget's disease. Any elderly patient with isolated ALP elevation, think about Paget's disease. Hemolysis, AST, this is ALT, right? AST, ALT will be normal. ALT will be normal. AST can be normal or very mildly increased. Okay. And ALP also will be normal, and bilirubin will be increased, and typically this will be an indirect fraction. Indirect, unconjugated bilirubin will be increased. And the clue will be LDH will be increased if it's a hemolysis. We know that. The examples are so much are there. Examples can be any type of hemolytic anemia. Any hemolytic anemia can do this. Okay, any hemolytic anemia, including malaria, autoimmune hemolytic anemia, PNH, or hereditary spherocytosis, anything that causes hemolysis, LDH will be elevated, and this will be the picture. Increased bilirubin, but normal or mildly elevated AST, but usually it will be normal. Everything will be normal. Only if bilirubin is increased, that to indirect fraction, think about hemolysis. Okay. In exam, another important clue is a patient who is asymptomatic, presenting with normal enzymes, ALT, AST, alkaline phosphatase, everything is normal. Increase bilirubin alone. In this condition, think about congenital causes in exam. Always think about congenital causes. Asymptomatic patient, normal enzymes, increase bilirubin, think about congenital causes. The main example is if it's unconjugated, predominantly unconjugated bilirubin is increased, means you're going to talk about Gilbert syndrome. Gilbert syndrome. If it's conjugated bilirubin, think about Dubin-Johnson syndrome, or probably a Rotar syndrome. Dubin-Johnson syndrome or Rotar syndrome. Dubin-Johnson, Rotar. So Gilbert unconjugated, Dubin-Johnson, Rotar conjugated. Remember, Crigler-Najjar syndrome patients usually will be symptomatic. Crigler-Najjar patients also will present in the same way. Okay, they'll have normal enzymes, only increase bilirubin, but they will be symptomatic. Okay, the bilirubin levels will be very high in Crigler-Najjar, especially in Crigler-Najjar type 1, patients can develop even kernicterus also. We know that it's a severe form of deficiency of the conjugating enzyme. So UDP1A1 enzyme, UDP glucuronidase transferase 1A1, isn't it? So UGT1A1 enzyme will be defective in Crigler-Najjar. If it's very deficient, 0%, type 1, present with kernicterus, very difficult to treat. Only liver transplantation can be done. If it's type 2, it will be mild, but still they can become symptomatic in certain situations. But usually they don't ask in exams. I don't know why. They tend to ask only Gilbert and Dubin-Johnson rotor. In that, the clue for Dubin-Johnson syndrome will be brown-black liver. Because of accumulation of polymerized epinephrine molecules, the liver will be brownish-black in color. That is Dubin-Johnson syndrome. And what are the important scoring systems? In hepatology, that's important. There are few scores they will ask you. One score is MELD score, which is something they will ask you. What are the parameters? CBI. What is CBI? Creatinine, bilirubin, and INR. Okay, this is a CBI score. Currently, MELD sodium is also there. As you expect, there will be additional sodium, nothing more than that. And next is CTP score, Child-Turcot-Pugh score. So what are the parameters of CTP score? You have ascites, encephalopathy, serum albumin, total bilirubin, and INR. Okay, so this is another score that they will ask you. So you can study the CTP score later on. The variables at least should be known. And third is the discriminant function, DF. This is also called as Madry score or Madry discriminant function, which is used for patients with alcoholic hepatitis. Alcoholic hepatitis. So what are the parameters? You use total bilirubin, INR, and prothrombin time or INR, and you're going to use total bilirubin. The formula is 4.6 multiplied by prothrombin time test minus prothrombin time control plus total bilirubin. Okay, so this is discriminant function. If the score is less than 32, no corticosteroids. The score is more than 32, we are going to give corticosteroids for the treatment of alcoholic hepatitis. Okay, that's it. 4.6 multiplied by PT test minus PT control plus total bilirubin. So the two parameters that are used is prothrombin time and total bilirubin. Okay, alternative to prothrombin time is INR. So here also I can write instead of INR prothrombin time. So both are same. PT and INR both are same, right? So see, remember, every score we are having two variables. Bilirubin INR will be there here also. Bilirubin INR will be there here also. Bilirubin INR will be there here also. Which means it's very important actually. So these are independent parameters of like liver dysfunction and death. So that's why those are important. So this table will tell you the important things about the pattern of LFTs and how to approach a patient with jaundice as well. So I think this marks the completion of our like marathon revision session. It's been like almost 7.5 hours of revision, 3.5 hours in the previous session and 4 hours in this session. So I think I've tried my best to complete as much as topics as possible. So I've covered more than 55-56 topics that are important and commonly asked from medicine perspective in exams. Hopefully this is going to be of so much of use to you guys. And thank you very, very, very much for your patient listening for all this while. And whenever anything you want, whenever you are in trouble, we'll always be there. Especially the Cerebellum team will always be there. And if you like our channel, please subscribe to it. And we are going to come up with more sessions like this in the future. And thank you so much. So I'm pretty much tired. So I need to come back again on Saturday to do the cardiology session. And hopefully I'll see more number of students over there as well. Thank you very much and have a nice time. Good night. Bye-bye. Let me end the stream. Bye.